right, everyone. Come on in, move down to the front. There's still seats. If you have an empty seat in your row, please fill it in. As you can see, we've got a lot of people. Still some seats down here in the first row. Well, this is the judges, but second row. Yes, I will do that. Feel free to stand at the back, eat, drink during the presentations, or you want to keep it lighthearted atmosphere. Still a couple empty seats, but anyone who doesn't want to stand up for the next 2 hours, we have an overflow room with a simulcast screen, and that's just opposite the doorway here, diagonally. It's to the right of the big step and repeat banner where you hopefully took photos. Otherwise, still a few seats. If you have a bag or something on a seat, we ask you to open that up for someone to sit down. All right, people are still flowing in, but we're a little bit past the time, so we're going to get started. My name's Jim Ryan. I'm the CEO of Medstro, but you may know me better as the guy who's been emailing you all week, so my apologies for all that. No more after today. Basically, sorry? Oh, they're asking me to announce the overflow room one more time. For those of you who've come in just now, we do have seating in an overflow room just opposite the door here to the right, where you can sit down and watch a simulcast of the event. If you didn't manage to find a seat, you're welcome to stand. There's no problem with standing at the back either. So where was I? The emails. Yes. In addition to all the emails I've sent you, I printed all your name tags last night, and I had to say, I think in this room we may have more graduate degrees than we have people. We have MD, MBA, MPHs, and MD PhDs, and I actually felt a little bad, so I put MS next to my name. And actually, we had a little joke that if aliens came down and abducted everyone at this event, we'd probably lower the average IQ of the world by 50. But anyway, let's not congratulate ourselves too much. So those are all the jokes I have. They weren't very good, so I'm going to turn it over to Jennifer Joe, the CEO of Medstro, who will be our MC for the evening. Jennifer.
Thank you, Jim, and thank you, everybody, for being here. Just a couple more housekeeping items. If you have your cell phone, it would be wonderful if you could turn down the volume of the cell phone, though we do encourage taking pictures and posting them on Twitter and Facebook. And if for some reason you have, is it a wireless mic? That will interfere with our sound system. So if you have a wireless mic, please, what would you do to a wireless mic? Turn it off. Turn off the wireless mic. As you guys know, we are live streaming this event. So we want to make sure that the sound quality is great. So hello, I am Jennifer Joe. If you don't know me, I'm a little Southern girl from Mississippi. I don't know if you knew I was from Mississippi. Yay, Mississippi, any Southerners? Yay! I came to MGH in Brigham to finish my nephrology training, and I got swept up in the amazing innovation space that is Boston and Cambridge. Now I'm the founder and CEO of Medstro and founder and editor-in-chief of MedTech Boston. So welcome to the Google Wearables and Healthcare Pilot Challenge. I want to thank Google. Yes, thank Google. Everyone clap their hands. Yay! They made this event happen. I want to thank them for allowing us to make this our second annual event together and their support for pushing boundaries and moving innovation forward. But I also want to thank you for pushing medtech and healthcare delivery innovation forward. We all know that the future of healthcare is collaborative, it's patient-centered, it's transparent, connected, data, and technology-driven. We also know that the entrenched medical systems sometimes struggle with these concepts and innovation. Today, by being here, you're hacking these silos that exist. You're talking, you're learning, you're collaborating, and you're pushing innovation into medicine, and that's hard. Thank you for doing that and being here. I want you to give yourselves a big round of applause for hacking silos. Yes, big round of applause for yourselves. Now I want to segue into talking about the amazing innovators who are about to tell us about their young, idealistic, rosy, tech-driven vision of the future of healthcare. They are sitting, or supposed to be sitting, right over here, because that's where we ask the pitchers to sit. So wave your hands to our 10 teams. Yay. Today, you're only going to see 10. But these are the finalists out of a total of 89 submissions that have been chosen by half crowd votes and half expert panel of judges. These finalists have been competing for the last 4 months through MedStro's online, interactive, transparent, collaborative platform, connecting you, the audience, with our amazing, and also with our amazing expert judges. They were chosen as the most innovative out of 79 other amazing high-quality, innovative ideas from around the country and around the world. So let me talk about those for a little bit. How amazing were these other submissions? 17 were from physicians, ranging from nephrologists, cardiologists, medical directors, obstetricians, rheumatologists, pediatricians, nephrologists, neurologists, from locally, like MGH, Brigham, and BI, but also further around like Chapel Hill and Children's Healthcare of Atlanta, to very far away places like Germany and Tanzania. We had 2 submissions from Tanzania. Anyone know? You guys probably know where Tanzania is, right? Small little, no. I'm a doctor, not great with geography. Also from the Netherlands, England, Ireland, and Australia. We're going to have 1 presenter from Ireland. 9 were medical students. We had 1 dialysis nurse. We had 1 pharmacist, a research technician, a surgical technician, a number of engineers, an EHR architect, a wearables developer, a master and fellows in system design, management program at MIT. We also had patient submissions. The future of healthcare is patient-driven. We at MedStro know that the future is transparent and collaborative, so you can still read all these submissions, the expert judge opinion, and the feedback online. These innovators received over 253,000 views, 2,988 votes, 885 thoughtful judges, feedback, and comments. It's been 4 months of online dialogue with experts, judges, you, and these 10 teams, you guys. You've taken their feedback, you've learned, you've adapted, and you're here today to present these refined, innovative ideas. Round of applause for the 10 presenters. Where are they? Can you guys stand up? Oh, okay, all of our presenters. So remember, we've brought together the most innovative minds, and that is you, to solve the problems that plague all of us in healthcare. Talk to as many people as you can, have fun, take pictures, make new friends, and future co-founders. Before I pass the mic over, I want to point out a few very, very important people who have made tonight possible. You guys already met Jim Ryan, the COO of Metro and MedTech Boston. He is our primary funder. Where did Jim go? Yay! You loved his jokes. You're going to applaud now. Yay! Jenny Whalen, she's our managing editor of MedTech Boston. She's worked tirelessly. Where's Jenny? Yay, Jenny! Most importantly, Irma, I'm not going to get your last name right, Rastegayeva, Google engineer, co-founder of TEDx Beacon Street, who's made it her mission in life to improve healthcare. Irma, you're going to have to stand up. Yes. Come up to the stage. Come up to the stage. We brought you flowers. And all the online judges. I don't know if we have any online judges here today. I think we do. Online judges, are you in the crowd? Leon, I know I saw you. They are invisible right now. But I want to thank them as well. So I'm going to now pass it over to Ned Sahin. He is going to be our keynote. Ned Sahin is the founder of BrainPower. Ned received his PhD in cognitive neuroscience from Harvard and has dedicated his life to understanding the neuroscience of autism and epilepsy. He's the founder and CEO of BrainPower, a local Cambridge startup with a neuroscience-based software and hardware system that transforms current wearable computers into neuroassistive and educational devices. Ned, come on up.
Thank you. BrainPower's tools help people with autism along their personal and unique journey toward self-sufficiency and beyond, and give parents and educators structured, numerical, and objective reports on how those children are doing toward their own personalized goals. Our software is based in cutting-edge brain science from Harvard and MIT and runs on modern wearables like Google Glass. Many members of the autism community have told us that our approach is transformative, a game changer, and one of the most creative and impactful uses of technology. And so that's felt very good to hear, of course. But tonight I'm going to try to explain a little bit why they may be talking about us in that way, and then implore emphatically for your help so that together we can rewrite the future of autism. So in this very brief talk, I'm going to tell you maybe a little bit that you might not know about autism, and a little bit you might not know about Google Glass. Well, that'll be hard in this crowd. And give a little teaser of some of our solutions and our team, and then announce something unique and new and special for the first time here for tonight. So because this is a brief talk, I'm only going to be able to cover part of what I would love to, and you may have questions, you'll definitely have feedback, and that's very valuable to us. So please, would you go to our website. It's simple, it's brain-power.com. There are a few contact forms. There's a one-liner, just put your email in, or a little more in-depth. Tell us why you're interested, give us some feedback. It's very, very important to us. I'll just do a quick sound check. Is it great? Anything okay? Yeah, thank you very much. So what is autism? Well, the first and most worrying fact is we really don't know. And it's shameful. We don't know. And we don't have a pill or a surgery or any medical intervention that is disease modifying that will relieve the symptoms of autism. And we also struggle to even find or detect autism. There's no blood test, there's no genetic test yet. Really, it's the behavior. It's about how does the child play with the parent and make eye contact that is used to assess, and then to assess over time. So these measures are not rigorously quantitative, not based in physiology, and maybe or maybe not repeatable when the family moves to a new doctor, to a new town. It may be that we're using this one word, autism, to signify many conditions that are actually very different. But at BrainPower, we're not deterred. We plunge on because we are driven by the fact that 1 in 68 children, 1 in 68, is now diagnosed with autism. Stunning. And because it's so expensive and so onerous for these families, and it's something that is very deeply personal and emotional and important to the whole family. So I've had the pleasure of meeting with many parents many, and over 1,000 have written to us through our website with long comments. And I've spoken with many, and I've met with people on the spectrum, children, adults, their teachers, their clinicians, a lot of clinicians. And while we don't know what autism is or how definitively to treat it, what I've done through all of the data gathering is to identify key life skills. These are life skills that are important for all of us, from which we can all benefit. Just they are particularly more of a challenge for people on the spectrum. And these skills are language, conversation skills above language, and outside of language, social engagement, including eye contact, abstract categories, and controlling of stereotypical behaviors. So that's a little bit about autism. So now, what can I tell you new about Google Glass? In this crowd, there are plenty of people who know everything there is to know about Google Glass, so you can take a nap now. But for the rest, maybe you don't know that Google Glass has a 9-axis IMU in it, meaning accelerometer, gyroscope, and magnetometer. Why is that important? Because this little thing measures the motions of your head 50 times or 100 times a second in a fraction of a degree. Maybe it's news to some that there's Wi-Fi and GPS and Bluetooth, and it's a connected device and transmits to servers that can perform complex analytics and then bring information back to the device. And maybe it's news that, in fact, inside this little thing here, in this 1.5 inches or so, is a computer that's more powerful than, for instance, the one I used as my workstation in college. So that we can run machine learning algorithms, we can run machine vision, we can do predictive analytics right here on the device without connection, and to run some of the software that we are, in fact, doing. So I told you a little bit about autism and a little bit about Google Glass. And so how could I put those two together? Have a think for a second. The first thing that we did is to address that social engagement piece, focusing in on eye contact. And amongst all the complexity, we brought it down to one simple question, which is, when the parent calls the child's name, does he or she look? And it's so simple, but it's so profound. Call the name, looking, not looking. Call the child's name, not looking. Call the child's name, not looking. Call the child's name with stress and distress. The child does not look, or maybe starts some behaviors. What's going on? Why? Well, we don't know so much about the why, but at the very least, we want to measure this. And so how do we do that? Well, with the camera, we detect faces using a classifier cascade. And then, with the microphone, and there are 2 of them actually, we stereolocate for that particular person, and when they call, for instance, the child's name. And then, the question is, what motions take place on the device? We have that accelerometer, we're measuring 100 times a second. So the question is, does the child look at mom? So simple. But this is the kind of thing that clinicians write down, paper and pencil, but would struggle to measure each and every episode of. We might get 1,000 data points a day, many more, and measure one day to the next. And that might be the day that the parent changed a diet or something else with that child, so we can be that benchmark, that numerical benchmark of, is the child engaging, or at least giving outward signs of engagement. And this becomes particularly important with autism, because we can ask a question never asked before, which is, even when that child is not giving any outward signs of engagement, let's say, not looking, not smiling, is he or she nonetheless hearing, understanding, feeling, and loving? So how on earth could we answer that? Well, we're also addressing this question with physiology. We're getting eye blinks and heart rate changes and breathing changes. So we can ask, even in absence of the signs of emotional engagement, is that child receiving and sending back love? I'll, as we go through the different tools, highlight the coder in my organization who's involved. And so this was partially and largely by Anita. Now, one thing you might be wondering is, will children wear this? Will children with autism wear this? It's a little bit newfangled. although remember they're digital natives, and it's something on their head. So we went to the best experts we could find, to clinicians, to teachers, to ABA therapists, to parents, and we asked, what do you think of our approach? Great. So what do you think? Well, I don't think it'll work because they won't wear it. And that intuition carried through, but we didn't stop. And so we're data-driven. So we found out by asking the children. And it turns out, actually, they love it. And some of these children and families are here today. I go on and fill the screen, but the point is, in fact, different areas of the spectrum, different ages, genders, whatever, really no problem. In fact, it's kind of hard to get it away from them. So how can we encourage eye contact? I said we can measure whether they're making eye contact. We know that's definitively important. We know that the person who's being spoken to feels more engaged if the child is making eye contact. So if we know that, wouldn't we want to encourage it, and how can we do it? So we have a suite of tools, and I'll just highlight one. The goal is to catch the child's attention to faces in the room. So what do? We paint them. We use machine vision to find the face. We use some algorithms to superimpose an image. And these are images that are optimized, not by us, but by the cartoon arts, by the Disney-type arts. And so that is not an angry bird. That is a copyright-free red bird cartoon. On my wife's face. And when the child looks, that catches the eye. And when the child looks, whoop, the bird goes away, and there's a reward. A happy tone, check mark, and a point. Remember, these are children, no matter what. They like to compete. They like video games. We're making the game of life a little bit more fun and engaging. So,
hi, I'm Ned Sahin. At BrainPower, we give experiences
Let it be.
that children love that help them learn crucial life skills that are particularly important for autism. That's social engagement, language, control of behaviors, category understanding, and so forth. So we give these experiences through the newest and wearable technologies like Google Glass, and it's based on brain science from MIT and Harvard. So far, it's been amazing. Kids like Sean immediately put it on, love it. These are digital native kids. This is not newfangled technology for them, but what's different is they're looking up and out in the world. With an iPad, they might be looking down, and it's hard to tear that away from them. In this case, we're bringing them back into the world and engaging directly with the people all around them, but in a totally new way.
seeing myself in stereo, but we're also going to see Sean in stereo. I don't know, Sarah, if Sean wants to come on up and give me a little high five. Anytime. You can just interrupt. And I also want to highlight Zulika, who's been one of the parents, and with her son Ryan, who's been very actively involved with us and giving us a lot of feedback. And I think we would be nowhere if we didn't have the feedback of the parents and of the children on the spectrum. This is not the exercise of a book. This is not a lab exercise. This is reality, and this is in people's homes. And so we need to know what happens in people's homes. So the next little tool that I'll highlight, and my clock is not working, so I don't actually know the time. The focuses on emotions. Once we get a child looking at the face, then what? What's the point? So there are a few tools in this suite, but one is about, again, playing a game to try to find and understand the emotional information that's on that face. So here, the question is this person surprised or happy? I have to choose. And the child chooses by nodding the head one way or another, or a hand gesture, because again, the head motions. And if he gets it right, he gets a point. It's that simple, but why is this important? Now, if we just gave the emoticon, and we do that in real time as well, we don't know, are they using that information any more than they use the information on the face? And this is the real people in their real lives, not in a book. These are their teachers and their parents and so forth. Sometimes it gets a little more difficult, and it's hard to know what the right answer is. And at the end of the day, they can review and go back to reality as they lived it that day and take that quiz again. And so that was by Katie. And so I want to talk to you a little bit about something that we haven't released publicly. And this has to do with this concept of stimming. If you're familiar, many people on the spectrum possibly gain comfort through repetitive motor actions. We don't exactly know why, but what it seems like from what I've learned, when a moment of distress is about to come, and autonomic signs are going through the roof, that's when, as a coping mechanism, someone might go into repetitive motions like rocking or arm flapping. And it's calming to the person, but since the other person probably doesn't know what's going on, it can be distressing. So it's a delicate line where we don't want to change someone, but in the same way that if you're learning how to give public speaking and you learn not to play with your keys in your pocket or other repetitive actions, we're trying to give coaching and then measure the outcomes of an alternative that is private. And I mentioned that Google Glass has all these features, but it has a private way of seeing, because there's a computer screen, hearing, because there's a bone conduction speaker, and even haptic feedback, the vibratory action of that speaker. So we can give feedback to the person as an alternative, so that before they're about to have an episode, we can give something that's interesting. And I say before they're having an episode, how can we know that? Well, we're measuring that physiology. We're measuring when there's signs of stress or distress, like heart rate and breathing changes, or the rocking itself. And so now I'm going to do something a little crazy here. And this, by the way, is the work of Sarah. I am going to go back one. Good. And now I'm going to try to do this in real time. So what we have done is create a version of this software now that listens to the body's actions. And I can't demonstrate the heart rate because I'm not that good. I can't change my heart rate for you. But I can do the physical actions. So let's try it. Okay, Glass. Help me relax. And now it's in a standby mode. So if I start rocking, it should recognize that, and there it is. Now what you can't hear, anyone hear that? I guess not, and that's the point, is it is a private speaker. But there's some calming music, and then the visual display starts undulating. Child can choose their favorites. We can push new ones to the device anytime from the back end, and parents can choose. It's more real time for me, it's jittery on the display. But it's a relaxing, it's a screensaver. How many times do you ever need to remember, oh, I think I'm about to get a headache, I need some time out. Imagine if this could predict beforehand, whether it's for a seizure or a headache or a behavioral episode. So that's what we're doing. And I'm sure you're having fun watching that, but I'll bring it back off screen. So we look at this as fake it till you make it. These are dance steps for life. Yeah, it's a little artificial to be reminded to look someone in the face, or to be told that they're smiling, or to be told that they're displaying signs of sarcasm or joking or idiom, which, by the way, we do as well in the language suite. But it's useful. And yes, it might be dance steps for life, but you're out there on the dance floor. And that's what we want to encourage, because our goal is self-sufficiency. So briefly about me, but we don't need that because I had that introduction. And they've told me that, if I have all these schools up here, it's going to make me look really smart. But they've also said that if you're the smartest person in the room, then you're in the wrong room. And so I've stacked the deck, and I've surrounded myself with some amazing, amazing people, many of whom are here. So would any Brain Power members stand up, please? Everyone you see is smarter than I am. That's my team. And we have a lot of fun, and this was at one of the events with parents. And the press have been taking notice as well. We've been covered in about 100 different press outlets, happily, TechCrunch and Wired and the Globe and so forth. And you can't see that anyway. Some very nice congratulatory quotes. And the parents, which is where it really matters the most, the parents and the children are telling us that this is bringing them hope and a plan. Because really a parent wonders, what comes next? And what am I planning for in the long term? So I'll end with our tools in action. And these are just a couple of the kids who've tried it on. And I'll let them speak for themselves.
Let's see if I look like an angry bird, okay? So you think that's a cool thing? Yes. Yeah, it's kind of cool.
I've never seen Jack's eye gaze be as intent and focused as they have been wearing those glasses in his entire 18 years of life. Even when he's doing his most favorite activity, watching a YouTube video or a movie on TV, he'll stop and rewind and watch little 3-second snippets of it. So his eyes are, constantly darting back and forth. But he's just, I've never seen him so intent with his eye gaze. Amazing. Amazing.
Amazing. Never once in his 18 years of life. Thank you very much.
Great. Thank you, Ned. I just want to make a quick reminder. There's lots of people here. Feel comfortable to stand up. Go get more to drink. The bar is open. We want you to feel very comfortable with coming in and out of the room. Get more food. Bring it back with you. There's also an overflow room because there's a lot of people standing in the back. So feel comfortable to go get a drink, go look at the demos, go to the overflow room, hang out, and maybe open up some seats. Great. So to get this kicked off, there's a lot of people in the back. If the judges, if you haven't turned around, there's the AC is not going to handle this soon. I'm going to go ahead, and we have 6 fabulous, fabulous judges, and I was going to introduce them, but I think you guys are tired of hearing me talk, so I am going to let them introduce themselves. There's 2 microphones in front of you, and there's 2 cameras. That hopefully we can show the judge. Looks like we're going to start with Dr. Freed because your face is up there.
Hi, everyone. I'm Naomi Freed. I'm the Vice President of Medical Information, Innovation, and External Partnerships at Biogen. I'm delighted to be here this evening.
Thank you, Naomi.
Hi, I'm Rich Klicklick. I'm a surgeon and a professor at Harvard Medical School and an XIR with General Catalyst Partners in Cambridge.
Thank you, Rich.
Hi, I'm Natalie Schneider. I'm with Anthem, and what a pleasure to be here with all of these smart people.
Hello, everybody. I'm David Ting. I'm a board-certified internal medicine physician and pediatrician at Mass General Hospital. I practice primary care, and I'm the Chief Medical Information Officer for the Physicians Organization.
Hi, everyone. My name is Chris DeLuca, and I work with Johnson & Johnson Innovation right here in the Boston Innovation Center. And really happy to be here. Congrats to all the different companies, innovators, and thank you, MedTech, for organizing this.
Thank you for being here. So without further ado, do we have our first presenter, Pavlak? Oh, sorry. Dr. Greenberg, you were sitting so politely.
Jeff Greenberg, practicing physician at Brigham and Women's Hospital and a medical director of our Innovation Hub, as well as a medical director at our Physicians Organization.
Big round of applause for the judges. Thank you for being here. And do we have Pavlok? Great.
Hey, this is for fun. How are you guys doing? How do I use the presenting? How do I use the slideshow?
The slideshow? There's a clip.
Oh, there it is. Hey, all. My name is Manish Sethi, and I am the founder of Pavlok. Today I want to talk to you about the end of addiction, which might sound pretty audacious, but it's something I'm really working towards. So this is one of my favorite quotes from a medical textbook. We are still standing on the bank of a river, rescuing people who are drowning. We have not gone to the head of the river to keep them from falling in. That is a 21st century task. And it's actually quite true. The problem today is that humans suffer from bad habits and addictions. The majority of deaths in the USA are caused by bad habits. Now, if you look here, you'll see that in 1900, the most common cause of death was through infectious disease. But we've managed to essentially cure that. It's down now to almost 60% of deaths are caused by heart disease, cancer, diabetes, and other lifestyle disorders. Things that are fixable just by changing your actions. Current solutions to break addictions don't work. Fewer than 5% of smokers are smoke-free a year later. Alcoholics relapse repeatedly, and sugar addiction is a big problem. But the question is, why do we have trouble breaking bad habits? And the reason why is because of our reptile brain. Our reptile brain, which is powered by instinct, controls most of what we do. The reptile brain moves towards pleasure. It moves away from pain. It doesn't understand thought or language. It's kind of like a 2-year-old. It's like if you try to tell a 2-year-old, don't eat sugar because you're going to get diabetes when you're 30, the 2-year-old's not going to understand that at all. They're just going to keep doing what they say. When you tell yourself, I shouldn't smoke, it's a bad idea, your reptile brain, which lives in the present, it doesn't understand future, doesn't understand language, it tends to just not listen to you, and that's why people continue to smoke. But there is a type of science, it's a type once very common, but now forgotten, and it works better than any form of therapy today. It disappeared in a period of 4 weeks in 1994. It's called aversion therapy. Pair an electric shock with an undesired action, and through classical conditioning, your brain creates an association and aversion to the action. It disappeared because of social reasons. It disappeared because of one particular study, which was not very popular within America. And because of that, one of the best ways to cure addictions just disappeared in a period of 4 weeks. Now, multiple forms of Pavlovian conditioning have been used, and they've only appeared in medical facilities. I swear to God, this slide is my favorite, but the typecast from Keynote to PowerPoint did not work until now. Meet Pavlok. So Pavlok is a wearable device. It's a small little module. It's worn anywhere on your body. Here you see it in the wristband form. It's a little bit smaller than this. It can go anywhere. It can attach directly to your skin. It can attach directly anywhere on your body through a necklace. It can clip onto your iWatch or your Pebble. It can attach by a magnet anywhere on your body. I just shocked myself. What's going on here? Pavlok uses a safe electric jolt to help you permanently break bad habits. Already, Pavlok users have used it to quit nail biting, eating sugar, drinking alcohol, and many more bad habits. There's actually 24 clinical trials that we have outside in an evidence booklet showing the success of shock on things like nail biting, smoking, gambling, obsessive compulsive disorder, even types of depression, chronic coughing, violent behavior, heroin addiction, and sadistic fantasies. Here you'll see a couple of them. So today's best type of Nicorette patch, for example, is 7.5% effective. In 5 days of adding shock while smoking a cigarette, 61.4% of 2-pack-a-day smokers never smoked again. They took problematic gamblers in 1980, I believe it was, who problematic gamblers who had lost their job or had gone to jail because of gambling, made them sit down and watch videos of themselves gambling for 5 hours, and none of them ever gambled again. The truth is, through classical aversion therapy, there was a very powerful way to remove bad habits, but it simply disappeared. So we actually ran a small trial. It's not a full official study, but in collaboration with UMass Boston, we reproduced the smoking study in a clinical setting. We had 8 people use Pavlok for 10 days to quit smoking. 10 days later, 6 of the 8 quit. The 7th quit last week. 7 out of 8 people quitting smoking, I feel, is pretty good. It's about 12 times better than Nicorette patches. So here you can see the effectiveness from our little mini trial. Number 1 was a shock from Pavlok. Number 2 was social support. We combined them together. So my hope here is that we can, that everybody here can help us upgrade humanity. We have evidence that our system can change behavior effectively and permanently. We've reproduced peer-reviewed studies, and we want to, with your help, to help reproduce more studies so we can make this proven technology and proven power be used for multiple different reasons throughout the world. Thank you.
So you need to stay on. Oh, what are you doing? Yes, you're gonna. We have 2 minutes of questions from the judges.
Oh yeah, for sure. That was for fun. It doesn't have to be actually.
So you said this disappeared in the 90s, and I'm not sure why, but what makes you think people want to be shocked?
Sure. Well, number 1, we've sold 3,000 units already. So for sure, there's at least 3,000 people who want to be shocked. It's my job, right? So the reason it disappeared in the 90s is because in one experiment, they tried to cure homosexuality. And in 1994, the American Psychological Association said aversion therapy is not effective for homosexuality. In a period of 1 month, it got a ton of media press. All university clinics closed, all government funding ended, and it disappeared like that. Sorry, go ahead.
How do we know this is safe, and have you put this on children?
I have not put on children. I do know it's safe because it uses extremely low current level. So if you have a current that is less than 10 milliamps, you don't even need to check with the government because anything less than 10 milliamps is extremely safe, and we release about 2 milliamps. I do know that there are dozens of devices that release voltages up to 20 times the level of ours. I'm sorry, 20,000 times the level of ours. And it's extremely safe. And also, our type of technology has been FDA cleared in the past as well.
So you've touched on this in behavioral therapy. There's both the negative reinforcement and the positive reinforcement. So obviously, this is really hitting on the negative. Have you thought about integrating positive reinforcements and kind of helping with persistence in that way?
Absolutely. So it's a big part of our plan, a big part of our process. And in fact, you saw in the graph that social support was the number 2 reason that people quit. So we use positive and negative reinforcement together. For the act of breaking bad habits, we have coaches who call you on the day that you purchase a Pavlok, that you receive it, and they tell you who would you like to be in a month, what would that person do in the next week. And over the next week, they track and help push them to do those goals, and they act as a social support. So we use positive and negative reinforcement as well as accountability in order to reinforce behavior.
So you said that you have some peer-reviewed publications. How many patients have been in them or subjects? And why the name Pavlok and not 50 Shades of Pavlok?
I like this guy. So we ourselves have not had any peer-reviewed studies. We are basing this on 21 plus studies that we found from 1960 through 1994. In the smoking study, the 61.4% smoking study, there was 800 plus patients in that study.
So first of all, I endorse the ambition. I think it's tremendous. And secondly, I think the burning platform is sound, and we all know, everyone in this room knows that logic does not prevail, and that won't help break bad habits. What I'm concerned about is the durability of the strategy. So in a controlled pilot, I can understand people being compliant with the device. I'm concerned about whether the habit is more powerful than complying with wearing the device.
Sure. So we don't use just the electric shock. It's what's called aversion therapy. So the way it works is We have 5-minute audio sessions that last between 5 and 10 minutes long, 5 and 10 days long. And what you do is you close your eyes and it says, imagine the blackness of smoke entering your lungs, see your lungs changing, and then it shocks you. Imagine the smell as you walk into a room and your loved one's smelling it, and then it shocks you. What happens is you create this actual physical aversion. So my example here is I used it on myself for tortilla chips. I cannot get my hands to touch Tostitos blue tortilla chips. It's like a force field is around it. We had 2 of our smokers who first used it back in September who tried to smoke again, and they spit it out and said it was the most disgusting thing they've ever tasted. It physically changes the flavor of sugar in your brain. So we know that, I mean, you can't, like, what I've noticed is it's kind of an interesting process. So if you shock yourself just a little bit until you don't want to do it anymore, this is the failure mechanism. So people will not push through and make it so it permanently deletes the habit from the brain. So if you imagine, if you know that theory of if you find your child smoking a cigarette, you make them smoke the entire pack of cigarettes and then they never want to smoke again. I call it white girl tequila syndrome. We force people to get to level 2 or level 3 of when they want to quit, and they feel like they've broken the habit, and we make them push through and get to the point where it's actually physically painful for them to break that habit, and we have not found very much recidivism. Very few people tend to smoke again.
Okay, thank you. Pavlok, yes. We want to see you. Why are you carrying that with you?
I was just for you guys.
Great. Next we have On Class. Yes.
I'm doing all right, getting good grades, the future's so bright. I gotta wear shades, I gotta wear shades. I got a job waiting for my graduation, $50 a year, I'll buy a lot of beer. Things are going great, and they're only getting better.
All right, my name's Ajay Kohli, and this is Sarah Foster, and we come to you from Drexel Medicine in Philadelphia, Pennsylvania, to present our platform called OnClass.
So we created OnClass to bring together surgery and pathology interoperatively to enhance collaboration to improve outcomes for patients with cancer. So I want to first tell you about a patient who was referred to us with an abdominal mass that was suspicious for cancer. And, you know, on exam, to tell you the truth, looking at her, she looked like she was 9 months pregnant. But after confirming and ruling out that diagnosis, we took her to the operating room. And in the operating room, they removed the pelvic mass, and I walked in as they were taking this tumor out. And they said, we need, you know, collaboration with pathology. So I volunteered to bring the tumor down to pathology. And I carried this 15-pound tumor down to pathology, and when I get down to pathology, you know, they are excited. They're asking questions. They want to know, how did this fit into the abdomen? How was it oriented? Where did it come from? And what's inside of it? So, to my surprise, they just start sectioning the tumor. And as they're sectioning this tumor, I couldn't help but think, you know, this reminds me of Turkey. But there were multiple extensive phone calls and conversations back to the operating room to discuss with the surgeon, you know, how did this come out? What did it look like inside the abdomen? And, you know, ultimately over the course of an hour, you know, basically they came to the diagnosis that it was a leiomyoma. So intraoperative consultation provides pathologic information to help guide the surgeon in how best to perform the appropriate surgery. But there are numerous challenges with this, and that includes limited communication and understanding between the two separate, you know, entities acting independently yet synergistically, trying to come up with a diagnosis. And I just want to highlight this with, you know, talking about the impact on survival. So the amount of tissue or disease left behind has a, you know, it's an independent predictor of the overall outcome and survival. And I just want to take ovarian cancer, for example. So the survival rate at 5 years with nothing remaining in the abdomen after surgery is 60%. But when you leave even the smallest amount of tissue, 1 centimeter, that drops to less than 20% survival at 5 years. And I just want to make this real for you. So if you take a look at your fingernail is about 1 centimeter, and just that small amount of tissue left behind in the abdomen can have significant impact on future prognosis and outcome.
And that is certainly a clinical problem that we wanted to address. And as entrepreneurs, as well as clinicians, we decided to build a platform that we like to call OnClass, Oncology Analytics. So OnClass essentially uses wearable technology to live stream what the surgeon is seeing, essentially the surgical field, straight over to pathology, and allows the pathologist then subsequently to send pathological data, be it immunological, genetic, histological, what have you, straight back to the surgeon. This allows the surgeon then to make a very precise diagnosis, not only to remove the cancerous tissue that's within the surgical field, but also the normal tissue that's at risk of becoming cancerous down the line. And as Sarah mentioned, we want to be as precise as possible because this has a large impact on future prognosis. And essentially, we're connecting two different silos of healthcare. There's the surgical field and then this pathological field that are really divided up within the hospital setting, and we're bringing them together to increase relational efficiency, which actually is a measured concept of taking hyper-specialized teams and having a better impact on their workflow. Because we're using this in the hospital setting, we want to make sure that we're hospital network compliant, and we've made all clarifications to make sure we're HIPAA secure. And finally, there are a couple cancer care centers in the country that have spent millions of dollars in their operating to create specialized operating systems that would essentially do the same concept. We are doing this at the fraction of a cost, all at the price of an unlocked cell phone. And so, we are clinicians, so we want to get data-driven medicine to back us up. So to move forward, we are doing a full clinical study looking at not just gynecological tumors, but also breast and colorectal cancers. And in the past, we have achieved success. We just currently submitted, another gross image, but we have submitted data on doing digital grossing using ex vivo tissue that's really been taken out from the body, and we've achieved the same results using our platform versus the golden standard, the pathologists doing staging on their own. But we have an esteemed panel of judges. Why should you guys vote for OnClass? And I will give you 3 reasons. The first is our wonderful team. It's not only are they in front of you, they're right behind you, hiding in the crowd somewhere. We've risen up to challenge every single clinical problem with technological innovations, and they have done it so far with a $0 budget. Secondly, our clinical team that has pushed us as founders of this platform into every single, they have pushed us so far to ensure that we go back and test all of our ideas and test all of the more than 3 million plus journal articles on cancer care. And finally, third, and the most important reason, for our patients. We've been given the worst diagnosis of cancer, yet they keep fighting. And we are privileged to stand by them while they do the fight and do the very best that we can. And that is the drive behind OnClass. Thank you.
So thanks for the presentation. I think decision support is critical in terms of expanding the using technology and expanding your knowledge around these operations. Can you tell us a little bit about how you're thinking of turning this into a business? So are you thinking of a business aspect of this?
Absolutely. So currently, not in addition to the technological platform, we've gone back and done a lot of literature search, trying to find the right, cancer models that we can potentially apply, not just in gynecological tumors, but also in breast cancers and colorectal and abdominal cancers. And once we potentially hope to file, intellectual property restrictions so that we can ultimately use this to advance our platform forward. But our goal really is of course, to use business principles and move forward, but it is also ultimately to make a difference in someone's life. So we are more than happy to take this open source and take this and, launch it to people if it has an impact on cancer care over 5 years.
And I was just going to comment too, if you look at the time spent waiting for a diagnosis to come back in the OR, the patient's exposed to the morbidity of prolonged anesthesia. The anesthesia, that's expensive, and then as is the OR time. And this could be done, I think, much more efficiently. Like I said, this was the first time I actually experienced it from the pathology standpoint. And, I'm used to standing in the operating room like, all right, when are they going to get back to us? But meanwhile, I understood what they were going through on the other side, trying to piece it all together. So I think just bringing these two entities together and, communicating is really going to lead to a more efficient practice, and it's going to be cost effective.
Yeah, congratulations on a great presentation and really a brilliant idea. I wonder if you've thought about taking this beyond just the walls of one hospital and consider what this might mean for, let's say, rural hospitals where they don't have access to a pathologist, at an academic medical center.
Absolutely. And I think, speaking to the benign GYN doctor in, middle of America who encounters a pelvic mass intraoperatively and, what to do. Do they resect it? Do they close it up? Do they send them to a specialist? Or can they actually consult somebody while they're there and optimize the outcomes instead of sending the patient back to surgery?
Definitely, and to really address the question of expanding to different hospitals, we wanted to make sure our idea was so solid, so sort of bulletproof that we get everything right before we go ahead and try to even attempt to scale it. So our clinicians, our mentors, really kept pushing us like, well, how are you going to achieve this, and what's the metric for that, and what studies do you have to prove this? So we've made it a point over the last almost more than a year now to ensure that we have all of the mechanics and all the specifics down before we really begin to move out to different hospitals. So we're ready now.
Once your pilot's concluded, how do you know you've been successful? So what are those critical metrics or measures that you're trying to meet?
So I will say that's something we've struggled with because I don't think this is something we're always measuring. So we need to go back and look in terms of overall survival rates. We need to look at anesthesia time. We need to look at communication. We need to look at variables that we're really not measuring right now. So honestly, I will say that's been one of our challenges in creating an IRB study is how are we going to measure our outcomes? It's a work in progress.
So is it primarily around surgical orientation of the specimen, and do you need a wearable for that? Can you use a camera that's on the light?
So again, that's been, some of our, what should I say, the people kind of helping us advocate how are we going to, define this and put it forward. Certainly that is one method to do it, but when you're operating, you need to be hands-free. And I think really seeing it from the surgeon's perspective, and not only that, you're using it to communicate with pathology. So the pathologist is also, dealing with the specimen, and I think looking at the both perspective and the hands-free is really the biggest component.
And as Ned sort of alluded to in his brilliant talk, the way he described Google Glass was fantabulous. And I believe that we are essentially utilizing the cloud capabilities of Glass, connecting to the servers and getting analytics in, which is actually not possible with the GoPro, which is not possible with several other, an iPhone or an Android. I love Android, love Google products, but and that's why we love Glass. But we feel that it would lead to great things with Google Glass in the future. Right,
Thank you. On class. Yes. Thank you. Next, we have, I think you guys did not give us a name, integrating mobile messaging and predictive analytics to improve chronic disease management. Yes. Oh, memorandum. Yes. Welcome. Memorandum.
Hello? Cool. Last semester, I got to interview a patient at the Brigham. She had Crohn's disease, and she'd been able to well manage it for over 30 years, but she came into the ER because of a recent flare-up. Why? She had trouble managing her medications. And so while I noticed that in the hospital room, there were machines measuring her vital signs, like her blood pressure and respiratory rate, there was nothing that asked her how well she could take care of herself. And we decided that we wanted to humanize digital health by asking those types of questions, the types of questions that land people into the emergency room. Unfortunately, this isn't limited to one incident. Over 50% of patients in the US have this problem, and about 125,000 die each year in the US. That could lead to up to 70% of total US hospitalizations each year at a cost of $100 billion annually. If we can solve this problem, we can save nearly triple that amount in associated healthcare costs. Around the world, it's a growing problem too, where 8.7 million people die each year because they don't have access to immunization records or medication adherence.
Our solution, Memorandum, utilizes personalized text message reminders and predictive analytics to improve patient care. A provider, either a pharmacist or a healthcare professional, logs in using a secure whitelisted email. The data is encrypted, and then they can enter in the information. Provider-driven input of information ensures that the data is both accurate and concise. Our data analytics algorithm provides physicians with a dashboard of individualized statistics that enables them to personalize care and track behavior over time. Here is an example of a reminder a patient might receive. Note the closed feedback loop, which asks the patient to respond whether or not they've taken their medication or not.
So what we want to do is be able to take this from a phone and implement it in a wearable, and we do that in two ways. First, you can either have the messages forwarded to the wearable, or you can also implement an application into the wearable, which allows the patient to respond either yes or no by either talking to it using Nuance's clinical speech recognition, or even just tapping a button on it, which removes a key barrier to entry. Integrating that along with integrating with EHRs allows us to minimize complications and personalize care, because it makes it simple for the patient and for the physician to monitor the patient. We want to focus on more than just medication adherence, though. We want to help people in third world countries keep track of immunization records, help people locally attend more appointments by sending them reminders, improve health literacy by sending them facts about their condition, and also improve patient engagement overall. Ultimately, we want to also utilize predictive analytics to give feedback to physicians using our algorithms so that they can personalize care and remotely monitor patient health so that there's a better experience for both sides. Overall, we can save around $290 billion, and this is a breakdown of how that happens via overtreatment, failure of care delivery, and lack of care coordination. Ultimately, the value proposition comes from minimizing excessive healthcare spending and optimizing the quality of care.
Let's talk about how we'll do that. Why now? Because as the US population ages and the ACA has new performance and financial incentives for hospitals, there's a physician responsibility to both improve the standard of care and help reduce medication complications. So let's talk about how we learned about this. We talked with the Center for Primary Care at HMS, as well as Northeastern University's Computer Science Department, about how we can use behavioral economics and software in order to facilitate behavioral change among patients. We have a partnership with HBS for a pilot trial in India this summer regarding medication adherence, and we're also working locally with the Crimson Care Collaborative, Partners Health, and Fenway Health. We have two phases to our pilot. The first is an 8-week trial that allows us to look at whether or not patients are getting an ease of use out of this type of system, as well as looking at the familiarity with technology and what kind of features they want. Ultimately, we want to see what the patients want before we proceed with an effectiveness trial. The second trial, based on phase 1 results, will look at effectiveness of a particular drug, for example, statins for high cholesterol. Looking at a measurable outcome like LDL, as well as looking at phase 1 information, will let us take both the information we gained from a phase 1 trial into an effectiveness study. The team involves students from a variety of universities. We all have engineering backgrounds, and a few of us are medical students now, so we're very well capable. We built this in January, and the product's already finished. Regarding competition, the problem with current systems out there is that no physician wants to see a chart. They want to see what they can do to help the provider, and that's what a predictive analytics backend does. Because we want to see patients as people, not numbers. Thank you.
So patient adherence to medication is absolutely the holy grail and will make a huge difference in healthcare and the costs and the outcomes. I'm interested in what you have developed that is different and not reproducible. What is your intellectual property? What do you have that no one else has built before?
So there's a few key things. One thing that we want to focus on compared to what people have built is that what people have right now is more where the user inputs all of the information, right? You download an app, you input information, or you set a timer for yourself to take medication. This is provider and input, which takes away a key barrier to entry, right? Because the physician is able to monitor data or monitor the patient by getting predictive analytics, and they're also able to input the data or have a pharmacist input the data on behalf of the patient, simplifying the process for the patient.
Have you looked at how you can integrate without having to have a physician or pharmacist enter the data?
Yeah, so we're looking at a few APIs, for example, DoseSpot, which is a prescription software, and they have an available API for you to easily integrate it so there's no manual entry. We were also hoping Aikido Labs would be here because they're also solving that problem. But ultimately, we'd like to take EHR information directly into this type of software, and that would automate everything. And so there'd be no extra work on either side.
So I'm assuming the patient has to enter the data on
Patient
whether
enters
they took.
nothing.
So how does it know if the patient took the medication?
The patient responds yes or no. On a smartwatch, they press a Y or N button. Ultimately, short of seeing them physically put in their mouth, no technology can validate that, but it's better than nothing, and we think it's a step in the right direction.
Just a quick question. So, if you're focusing back on the patient for a moment and less on the technology, how do you see the overall solution of actual adherence improving? And how does that relate to companies like PillPack and kind of looking at it from a less tech perspective?
We've been looking at a few behavioral economics theories, such as loss aversion. So say every day you'd be entered into a local lottery, and you have an incentive to take the medication. Otherwise, people are more averse to loss than gaining the health benefits. So short-term rewards will psychologically wire them for long-term gain.
And last question, have you thought about collaborating with Pavloks if they don't take the medication that shocks them?
I guess
Thank
we
you.
should talk afterwards.
Thank you, memorandum. Keep your cool in the OR. Yes. Music.
All right. Is this on? Are we working? Good evening, everyone, and thank you so much for allowing us to be here. I'm Courtney Hill.
And I'm Allison Arnsman.
And we are very excited to share with you our idea for making the OR a safer and warmer place.
If you ask any patient what they remember about being in the operating room, cold is almost always part of the description. In the United States, over 1 million patients become hypothermic in ORs every year. This is problematic for several reasons. One, it increases the rate of wound complication and wound healing problems. It increases the rate of cardiac complications and death, and increases the number of transfusions in our surgical patients.
So why does it have to be so cold? Well, the temperature in the OR is driven primarily by the surgeon. And our friend Mark here has kindly shown us the many layers that one might have to wear. The surgeons are performing physically and mentally stressful procedures. And so it is more comfortable for them to have a cooler OR. We know this, and we try really hard to keep the patients warm. We use fluid warmers, warm blankets, and forced air heating.
While patients are freezing, the staff remains uncomfortable. Some of the staff members are in fact cold because they're not scrubbed in, whereas those who are wearing all these layers of garb, and sorry that slide didn't work just perfectly, are really quite warm and have a much higher level of perceived temperature. Here you can see one of my colleagues on the left with a sweat stain on his brow after we replaced someone's hip. In the middle you see one of our OR nurses. She's wearing a blanket around her waist to keep warm, while one of the anesthesia staff members is literally huddled under a blanket while ventilating a patient. The current solutions just aren't cutting it, and they lead to a higher risk of contamination. You can see here a cooling vest that's marketed online. We've never actually seen this used by operating room staff, but it would actually physically tether the surgeon to a cooler and what looks to be something like a grocery cart. On the bottom is a picture you might see in our operating room. This is one of our scrub techs, Michelle. She literally wears a dollar store fan around her neck in the operating room to try and keep cool. Other surgeons might wear a cool rag or an ice bag over their necks to try and stay cool during a particularly strenuous surgery.
Wristify is an ingenious device that uses thermoelectric cooling and heating to improve thermal comfort. We hope to bring this to our OR and have all of our staff wear it.
It's interesting in that it requires no external power source. It has no moving parts. It would be easy to clean, and it can be worn really anywhere on the body.
The original prototype was for the wrist, but as you can see, it can also be worn on the head or the neck, and these are actually found to be more efficacious areas.
We have 5 surgeons who have already agreed to pilot this, and more ask us every day. We're set to pilot this in 5 operating rooms. Our study design is really quite simple. We'd be collecting data that's already being collected on a minute-by-minute basis. We'd collect 3 patient temperatures, one in the preoperative area, one 30 minutes after incision, and one in the postoperative area. We'd also be collecting the OR temperatures at these exact same times. iThermometer might be able to help us out a little bit with that part of the study.
That's right.
We plan to use a crossover design. So actually, we'd have 5 groups of OR surgeons, anesthesiologists, and nurses that would wear the device over the course of 10 OR days. On 5 of those days, the device would randomly be turned on, and on 5 of those days, it would be off. The wearer would be blinded to whether or not the device was on. Again, we'll be collecting patient temperature, OR temperature, and a short survey to look at staff comfort on those days. We think that this is an exciting idea because it has the potential to impact every single patient undergoing surgery. In terms of patient outcomes, it could reduce wound infections, and it could lead to fewer cardiac complications and even deaths. In terms of surgeon efficiency, a comfortable staff is a more efficient one. We think that it could even reduce staff turnovers and the number of breaks that people need to take in terms of the scrub techs. In terms of overall staff and patient comfort, it would be difficult to imagine the benefit it could have on a really ongoing problem. And finally, we think it has the potential to have a widespread impact on cost. In terms of the amount of energy that is required to heat and cool an operating room and these spikes in temperatures, we think this could really be a novel way to help even that out and keep the operating room at the same temperature. We're really excited and think this has the opportunity to make the operating room a warmer and safer place for our patients.
Thank you so much. We'd be happy to entertain questions.
So Courtney and Allison, great job. I think you've done a great job identifying the problem. This is clearly something that has been tried before in other form factors, so I think it's a nice way to look at Wristify and maybe apply it in this setting. My question is more around your relationship with Wristify. So I would understand if Wristify were positioning this as a product to be used in the OR. Could you tell us a little bit more about your relationship with Wristify, and if you're not related to Wristify, how you might create some sort of intellectual property around this based on your efforts?
Sure. So we had no relationship with Wristify prior to 3.5 months ago. We saw the idea, we saw the product, we saw a need for it in the operating room, a place that we're pretty familiar as surgical residents. We spend a lot of hours there. So we were excited about how can we take something that's really going to improve patient care and actually enhance a surgeon's experience and even everyone in the operating room's experience. And so I think there is a huge space for that. I spent some time getting my MBA as well, so I've been thinking a little bit about that idea. We have yet to work out any formal details with Wristify, but certainly the healthcare space is a huge one, and I think they haven't necessarily captured that market or thought about that market, but I think we'd be eager to help them do that.
Can you just explain how the Wristify device is working? Because I'm not quite sure I caught.
Sure. So it uses thermoelectric heating or cooling. So it's called the Peltier method. We actually, Matt from Wristify is here, and he might be able to give you a little demo on it. But it basically is a tiny square that's something that I guess is also used in solar panels and other, they're material science folks. And so it's battery powered, but it also uses the energy that we give off and converts that to either heating or cooling based on the direction of an electric current. It's pretty amazing. While we talk about it doesn't necessarily change your core temperature, if it could change a surgeon's tolerance of a certain temperature in the operating room, even by a few degrees, it could make a huge difference. Any other questions?
So you said even if it could change the temperature by a few degrees, do you guys know what is the potential of Wristify in terms of how much does it change the temperature, and do you have sort of solid metrics about what your target is, and do those two reconcile?
Sure. So what we do know is that operating rooms are kept pretty cool. It depends on the surgeon, certainly, but we also know about some ideal temperatures in the OR, and that's from some data from the 70s. I imagine before there was the forced air heating and all of that we can currently use. The ideal temperatures are at least 73 degrees. Most ORs, I would say, are in the mid to high 60s.
Most orthopedic ORs are actually about 60 degrees.
So we don't have exact data about how comfortable the Wristify can make you feel. But that's something that we will gain from this pilot study. So the concurrent use and then the concurrent data taken from the OR temperature will give us that sort of information. And then also we'll be seeing how the patients fare, which is the real focus.
Great, thank you. Keep your cool. Next, we have data-driven concussion recovery.
Hit me with your best shot. Why don't you hit me with your best shot? Hit me with your best shot. Fire away.
Concussions, hit me with your best shot. Are we ready? Good. Okay. So my name is Bill Yonker, here to talk about concussion recovery. What is a concussion? A concussion is a rotational acceleration of your brain from an outside impact or something that looks a little bit like
that
this.
puck is chipped by. Chara's got to let him go there. But not only does he ride him into the boards,
Not
he puts
good.
him
If
into
that's
that
not
dangerous
serious
spot
enough for
where that-
you, a concussion is a traumatic brain injury. How do I know this? Well, this is a picture of me. Two things to point out. Yes, I'm a little heavier right now. Thanks for noticing that I've gained some weight. The second thing to point out is that I'm actually severely concussed in this picture. So this is taken during an Ironman triathlon. I'm about halfway through the marathon portion of the run. Earlier on the bike ride, I had crashed, hit my head, got concussed. Like a lot of people, I thought a concussion kind of just took care of itself, so I didn't do anything to recover. And because of that, for several months, I had headaches, sleep problems, dizziness, all sorts of issues. I was also just kind of slowed down. I had this brain fog. And as a direct result, I ended up here 7 months later, back in an emergency department, another bike crash, another concussion. Now, I had never taken a selfie before. I don't think I've taken one since, but I think I know at this point I kind of knew the past 7 months have been hard, so the next 7 months might be even a little harder. And I was right. I lost my job. I couldn't see friends or family for a lot of time because of this. But on the upside, I had plenty of time to research concussions. What did I find? It's a big problem. 45 million occur worldwide each year. In the US alone, 3.8 million just from sports-related concussions. And it's something like only 1 out of every 10 is actually diagnosed, so this number is much higher. It's a serious problem. If you have a history of head injuries, you are 300% more likely to be diagnosed with depression than someone that has never had a head injury. In Denver, they did a study. 96% of inmates had some form of traumatic brain injury, mostly concussions, prior to being incarcerated. Medical community is catching on. This is PubMed concussion articles for about 15 years. We're flat, 100 a year. This year, we're going to do upwards of 1,000 published articles on concussion. This is the big one, 7 to 10 days. If you read most articles, it'll tell you that you will spontaneously recover from a concussion in 7 to 10 days. But Children's Hospital of Boston and Philadelphia decided to actually track this. What did they find? If you do not have proper intervention, it's more like 100 days to recover. That's a big difference, 100 days versus 7 to 10. What do we talk about, or what do we mean by proper intervention? Well, if you went to an emergency department today, all they would give you is a piece of paper that would basically say, we have no idea about recovery, so good luck. We hope you find your way through the other side. If you don't, maybe you can find a specialist to help you out. And in practice, it looks like this. Doctors recommend everything from cocoon therapy, which is you sit in a dark room for weeks or months at a time, to the other end of the spectrum. You feel fine the next day, get back out on the field. Neither of these are helpful, neither of these are safe. What is helpful? This is from the Department of Defense. Concussions are a big issue with veterans, and this is basically a progressive return to activity. Simplified, it looks like this. At injury, let's restrict your activity and gradually add activity until you get to baseline. In concussion, we're concerned about 4 types of activity: cognitive activity, physical activity, sleep, and mood. So to me, this looks like a graphical algorithm. Think about that. We're saying, don't even worry about a concussion, do nothing for your recovery, and now all of a sudden we're gonna throw this at patients, the most complicated patient packet there is. Let's put a graphical algorithm where it belongs, on a wearable. We can track a patient's activity in real time, give them real-time feedback, and get them that nice linear progression back to baseline. Basically, we're trying to create a cast for the brain. So besides the peer-reviewed research telling us this will work, why else do we think it will work? Well, this is Dr. Robert Cantu. He was my doctor while I was recovering. He literally wrote the book on modern-day concussion research. He's volunteered time to me to tell me that he thinks this is a solution that will work, and he thinks patients will recover faster with it. And then Boston Children's Hospital, they have agreed to do a pilot with me. First of all, we'll start with the Misfit Shine, so we'll be able to track sleep and steps and do some other analytics on an app. And then from there, hopefully we'll get a more robust wearable, so we'll be able to track all these different parameters that we need to track. The important thing to remember is that what we're trying to do is take the millions of people each year that are going to have injuries that look like this, and as quickly and safely get them back to a lifestyle that looks a lot more like that. Thank you.
Great application here. Can you talk a little bit about the potential of using this also to capture baseline data? So, schools, high schools, sports teams, they're always looking for baseline impact studies and then compare if there is a head injury. Is there any application for this?
Yeah, 100%. Baseline is kind of the holy grail. I think what's difficult that you run into is who pays for this. And so if we can prove that it helps with the recovery, it's a lot easier to get the provider or the payer to pay for it. The baseline's a little trickier because who pays for that up front? So ideally, maybe at the professional level where they have that kind of budget, we can start there. At the youth level, I think that's a hard ask. So I think we really have to start with what do they look like post-injury? How do we get them back to baseline?
So what is the innovation? Is it the data and analytics and the algorithms that sort of mirrors that diagram you showed? And that
yeah, exactly. So it's taking that diagram that was very complex, and that's covering a lot of things. For instance, at stage 2 of recovery, you should be at 60% max heart rate for 30 minutes if you're, and see if you provoke symptoms or not. And if you do, you need to take a step back. What we want to do is just do the data around that. So we'll create the first feedback loop. So we'll actually get real data from people. Because right now, if you go in and your doctor tells you to go get your heart rate up for 30 minutes, no one has a heart rate monitor to do that. So we don't have to have any actual data to back that up. It's all done subjectively. So we'll create that data feedback loop that no one else has. And from that, we'll be able to iterate.
So are you viewing this as a sort of consumer product or medical product or both? And are you planning or would you plan on FDA approval or submitting this to the FDA?
Yeah, great question. 100% a medical product. I have no desire to sell this as a consumer product. FDA approval down the line for sure. I think it'd probably be more of a de novo process. Class 2, it's not an invasive device, but there's some 510Ks to back that up. So I think you could get through that process kind of on a 510K timeline. I had a conversation with a chief medical officer of one of the biggest private payers in the country. They know this is a problem. They're very willing to pay for something that gives data that's going to improve the outcomes. They're trying to internally figure out how to take care of this problem. They know that patients aren't recovering. That's a problem because their job is to get patients to recover, but it's also a problem because it's costly. There's a long referral cycle that happens when you don't recover properly, so it gets costly.
Great, thank you. Thank you for everybody's fantastic attention, the 5 wonderful presenters. We now have a 15-minute break, so you can stand up.
8 o'clock. So we'll come back here at 8 o'clock, and we promise we'll try to get more chairs.
Great. Glad that everyone is back, and we can go ahead and get started. I hope you had some nice drinks and some nice food. And next, we have wearable mobile support for orthopedic rehabilitation, all the way from Ireland. Yes.
Good evening, and thanks, Philo, for the introduction. I've come here this evening. My name is Brian Caulfield. I'm a physical therapist working in University College Dublin. I've come here this evening to talk to you about 4GPT, which uses the mobile phone as both the wearable sensor and the computing hub in a solution for the challenges that face patients and clinicians involved in orthopedic rehabilitation. The typical model for orthopedic prehab and rehab and joint replacement incorporates a combination of inpatient care immediately after surgery, outpatient visits and home visits, and of course the patient-led effort that takes place in the home without clinician supervision. The average cost of a joint replacement in the USA is $30,000, and the rates of surgery are set to rise sharply in the coming years. In the next 15 years, they're set to rise by a factor of about five. So this there's an associated drive towards efficiency, and it's putting pressure on the model of care. Firstly, the length of stay in the hospital has been reduced. There's also pressure to limit the number of outpatient and home visits, all of which means that the patient-led effort is more important now than it ever was before. So we need to support the patient. But at the moment, we're not supporting the patient, and patients are typically reporting a lack of knowledge and confidence regarding the detail of what they're supposed to do at different points in rehabilitation. In particular, their self-reported exercise therapy adherence rates are alarmingly low as 30% in a lot of cases. So we're developing 4GPT to address this. Its core contribution is its capability to provide for remote exercise management and monitoring, but it also addresses patient education, progress monitoring, and communication. In terms of education, it looks at things like self-care, walking aids, transfers, recommendation for resumption of daily activity, using a combination of video and text resources. But as any physical therapist will tell you, the cornerstone of successful rehab is effective implementation of exercise therapy. And 4GPT allows the therapist to reach into the home and virtually manage implementation of exercise for the patient. It does this through an interactive exercise biofeedback interface. Interface that provides real-time feedback, uses gamification to make exercise interesting, and at the same time monitors compliance. It leverages a few key IP assets that we have that set it apart from other feedback systems. First is the use of the mobile phone as the sensing device, thus removing the need for expensive sensors to be purchased. The second, my monitors are gone, is a massive library of over 8,000 motion files that we've put together and used to develop machine learning-based classifiers that take sensor data from the phone during exercise performance, match it against expected clinical norms, and then provide the patient with the detailed and helpful feedback that they would get if a therapist was available in the room. And we implement it in two different modes. Sorry, I can't see the slides here. The first mode uses the mobile phone alone. The patient loads up their app with their prescription, arms it to go, puts the phone into a strap on their leg, and then the sensor sets to work. And the patient gets guided through the program using real-time audio feedback. Their performance is recorded so they can review summary graphs and reports afterwards. In the second mode, everything works as before, but in this mode, they'll also get some visual feedback via, because we're streaming to a second device, they get visual feedback via an avatar or a game-type interface. We also have periodic tracking of progress and also communication between patient and clinician available on it. So this has the potential to empower the patient and lead to real impact in the clinical setting. It's very novel. There's no system that's out there that does what this does in terms of having everything in the patient's pocket, all in one place, and the requirement for no additional cost. So we want to do some pilots. We want to look at putting this in various different implementation modes into the clinical setting, looking at it in its different iterations with a phone alone or with another device. Compare it in pre-op and post-op deployments, both pre-op and post-op deployments, and look at specific evaluation criteria like patient satisfaction, quality of life, functional performance, utilization of services, and also looking at things like complications after surgery. The good news is we're ready to do this. We've done some pilots already of prototype devices in the clinical setting, just looking at user feedback, etc., and acceptance. But we've also secured full commitment from the two largest providers of orthopedic surgery, joint replacement surgery in Ireland, in both the public and private setting, the Beacon Hospital and Kappa National Orthopedic Hospital, to actually run pilots for us. And they've also committed to take this into their ongoing service if it is proved to be successful at pilot stage. So thank you very much. I'm sorry, the monitors weren't working here, and sometimes they were and sometimes they weren't, so it was a little bit kind of strange there.
Thanks for that presentation. Sounds really exciting, and I like the notion of using existing mobile devices that patients have in their possession. Can you speak a little bit to the minimum requirements in terms of the mobile devices, the platforms that this works on, and the specifications?
We've been using it on basically any smartphone. We've been using it in our prototypes on the cheapest SIM-free Android phones that we can get.
Just 2 questions. So do you have IP around the analytics you're running on the accelerometers in the phone?
No. The IP, we've one form of protectable IP in that we filed a patent application for the use of the phone itself and the sensor in the phone to provide detailed feedback on discrete body movement. But there's a lot of people obviously measuring activity with phones, but none of them are measuring discrete joint movement.
That's what
So that's one piece of IP we have. We have, I suppose, a step ahead of the rest of the market in terms of the motion libraries that we've created, but the machine learning algorithms that we are using in themselves are not novel.
Okay.
But it would be very hard for somebody else to get in there and get ahead of us.
And just the second question is, what you're listed as at the university? Is this a company or
it's not a company.
Yeah.
If people are interested in it, we want it to become a company, but it's not a company today.
Brian, just a quick question, Chris over here. So thanks for coming to Boston, making the trek over. So welcome.
Delighted to.
Thank you for doing that. My question is around your kind of patient journey, and are you trying to own that kind of overall rehabilitation experience?
Yes.
I can speak from a personal perspective as a person who's had multiple knee surgeries. You truly are on your own, so you've got really limited resources in terms of continuity once you leave that hospital. But back to the point, if you're focusing on owning that, you know that there are some major players. Full disclosure, Janssen Healthcare Innovation has a Care for Today orthopedic solution that's also a patient portal, and there are a number of startups even in this ecosystem right here in Cambridge that are working on HubSpot-like models for rehabilitation. So, question of ownership, but also thoughts around expanded partnerships in technology.
Yeah, I mean, look, we're academics. We're not necessarily entrepreneurs. But we want to see what we're doing translate, and if that means partnering with small business, big business, whoever, we want it. The reason I do the work I do, and the reason I get out of bed in the morning is to try and walk into a store someday and see something for sale that was developed in our lab, and that has happened. But also then go into a hospital and see something that was developed in our lab in a hospital. And regardless of who ends up being the person who brings it there, I want to be part of the process, but don't necessarily want to, I'm not planning on retiring on this, but I do want to see it working.
Great. Thank you, Brian. And a special big round of applause for Brian, because we are having a little bit of technical difficulties with what I'm told is maybe electrical surges. So the monitors up here are flashing. Maybe the Pavlok machine is causing electrical surges. So our monitors are flashing, and Brian did an excellent job of pushing through. We are hoping that they are working now, but we do want to let you know that our presenters are working through that. So next we have Alex with using the Muse for measuring visually induced motion sickness during HMD uses.
Oppan Gangnam Style. Gangnam Style. Oppan Gangnam Style.
It's kind of funny that no one is using this Gangnam Style song as answer. Ah. So it looks like it's a new boom of stereoscopic 3D head-mounted display. If you ever used this before, you may have noticed that if you use it for a long time, you will starting to feel strange. And you will feel disoriented, you will feel nausea, and you can throw up. But the serious part is this. These symptoms last even a couple of hours, even after the exposure. But the most important part, most serious part is, if you ever experience this, you will never want to use this device again. So last year, we published a paper about the motion sickness, especially for the 3D conditions. In our paper, we proposed likely causes of 3D motion sickness. One is peripheral depth distortion, and the other is a decoupling of egocentric motion and perceivable depth motions. But this is a hypothesis we're proposing, so we need to test it. So we designed a study, actually 2 studies. One study is we are comparing the amount of motion sickness caused by 2 different types of projection configurations. One is a single screen split display, that is the usual stuff, people using it. The other is a dual screen angled display, which we believe that might reduce the motion sickness. And the other one is parallel. This one is comparing the motion sickness caused by 2 different rendering style. We compare the parallel and converged axis styles. But with this study design, the important part we realized is actually measuring the motion sickness is really hard. Most of the people have been using something called simulated sickness questionnaire. But it's a questionnaire. It's a subjective evaluation of their motion sickness. And it has to be done twice, before exposure and after the exposure. So we have no idea what's happened in between. So we're trying to find some other objective measure that actually gives some numbers to me. And we found that few measures actually shows the possibility of measuring the motion sickness. One is body sway variability, and the other is blood pressure and blood pulse rate variability. But how about the EEG? EEG is directly measuring the brain waves. Motion sickness happen in our brains. So, and it has been shown that some paper actually shows that it is possible to measure motion sickness with full-scale EEG. But as you can see, it's really bulky. And it produced like hundreds of data in different channels. And that data contains lots of errors, noises, and there is a coherence problems, interference problems, and you cannot even wear with HMD. So I have to find some alternative way. And then I came across something called the Muse. You guys probably have seen that demo over there too. But this Muse is basically really simplified version of EEG system. It's compact enough, as you can see, to wear with HMD. And it's focused on only 4 major brain waves. So analysis will be much easier, and I think that's the reason I think I can find motion sickness, the dependable measurement using the Muse. So as a conclusion, if the Muse turns out to be the dependable evaluation method for motion sickness, it helped to design the better stereoscopic HMD so that these guys doesn't have to be suffered by motion sickness. Thank you.
So thank you for your presentation. And I suffer from motion sickness, and I don't even have to use the ocular rift or anything else. I just get it when I go out. I'm interested in how big you think the market is for using the Muse in this application, and back to the problem that I have, my mother has, and my daughter has. Is there maybe another market for people that just have motion sickness without ever using one of these 3D devices?
I think I can think of 2 ways to utilizing the Muse, except what they are intended for. One is this actually provide a really cheaper way to it provide kind of cheaper way to measure the brain waves, and you can measure the motion sickness. So there's a lot of people who wants to measure it. The motion sickness is the most important single factor in HMD industry right now. So people wants to measure and wants to solve that problem, but they don't have any measurement yet. So we are providing that, and they will have tools to improve their system. But if we improve the HMD systems, someone has motion sickness, we can using the HMD to treat their motion sickness by, I just talked to one of you guys at break time, and they actually told me that it can be used for repeated exposure therapy. So if someone has vertigo problems or motion sickness, you can induce the motion sickness, similar, but in a controllable way of the virtual reality, so that they can, by repeatedly exposing themselves to that strange condition of motion sickness, you can overcome. Your sensor will, your brain will adjust that conditions. So I think that will help, I think.
Just, could you tell us a little bit more about that therapeutic approach? So it sounds like you're getting, cheap data. It's easier to get, this device onto someone's head. You're inducing it through, whether you're setting up shop, frankly, on a cruise ship and just getting people in line and having people, sense data and reacting to that, or if you're doing this induced through virtual reality. I think, put that aside for a second, I think the use of Muse in terms of improving the motion sickness symptoms, can you tell us how that process happens?
How that process? First of all, at current stage, there is no dependable measure for motion sickness. So even though we have idea that theoretically it improved and it reduced the motion sickness, we cannot even prove that it works. The Muse can give a solution for that. But also it's dealing with much simpler data, so it can avoid all this mass of data streams.
Great, thank you. Thank you, Alex. Next, we have patient monitoring and Ebola response, Proxome.
Stopping us right now. I feel so close to you right now.
The words to that song were, I feel so close to you right now, it's a force field. So I want you to think about proximity, and you have our team, Proxome. Our team is made up of 3 global health students and 3 engineers. So we have a lot of experience in what we're talking about right now. Proxome is a pair of wearable devices that monitor temperature, heart rate, and proximity in infectious disease settings. As a group, we started at the Stop Ebola Hackathon in December 2014 to create a solution to monitoring and evaluation needs for Ebola treatment centers. Our goal is to expand our idea to areas where there are other infectious disease settings and there are other low resource areas. Proxome is made up of a beacon, which is on the patient, and it's connected to a beeper which is worn by the clinician underneath their personal protective equipment in an Ebola treatment center or in another infectious disease setting. There are several different challenges in infectious disease settings. There's the appropriate infrastructure and human capital is not always available to tackle complex infectious disease outbreaks. Proxome is reusable and can be disinfected to prevent the transmission of disease, which is extremely important in low resource settings. The device is simple, transparent in operation, and customizable so that workflow, language, alarms, and privacy protections are accessible to anyone with minimal training. Therefore, even in an area where there are not enough clinicians, those clinicians will be aware of their patient's temperature, heart rate, and proximity, and will receive alerts when something is going wrong with the patient. Finally, Proxome is cost effective. We estimate each beeper to cost around $50 and each beacon to cost around $10 to $20. Our devices are affordable and can be reused. Its ability to be reused, customizable, and the fact that it's cost effective make it suitable for pre-positioning and at-risk communities before infection strikes. Proxome is innovative for several different reasons. The first one being that it's made with open source software. And as such, the technology would be available for local scrutiny and adaptation in very diverse environments where trust is at a premium. We are developing a device that is clinically accurate, enabling access to high-quality ECG waveforms and estimates of core body temperature. Proxome is proximity-enhanced monitoring for clinicians. In low-resource settings, these three aspects are very unique. They are not, you do not see them everywhere. To execute the pilot, so far, our group has won the Stop Ebola Hackathon in December 2014 and the Global Health and Technology Meetup at Boston University in February 2015. We have gained the support of MGH's Center for Global Health, Medtronic, Camtech, and International Medical Corps to help us in developing our device. Our initial funding allows us to get hands-on feedback from experienced users based on real hardware and software. Our affiliation with International Medical Corps allows us the possibility to rapidly and efficiently test a small production run of about 100 beacons and beepers with a budget less than $50,000. The diversity of interest in this product is what will make it deployable in the very near future.
We have a short demo of both the beeper over there and the beacon that I'm
Battery.
wearing it. You can see the
Flash.
field programmable component is done with software that can be modified by untrained people, doesn't require programmers. You can see here an earlier prototype of what I'm wearing now with the full ECG as well as beat-by-beat heart rate monitoring. And Sean will demonstrate some of the aspects of the built-in voice recognition technology, which doesn't require connection to the cloud and is completely open source as well, comes from Carnegie Mellon. So both components include, and the programming and customization in this system are entirely accessible
Battery.
in the field.
Oh, just that we can change the vocabulary in that little interface that you saw. It's Node-RED. It's something from IBM. It's open source software. It's very simple to add on different sorts of components. We're using low-energy Bluetooth for talking to the devices. We're trying to keep it as open, use standards where we can. This is sort of the larger, bulkier version. We have a smaller version we're hoping to make using the Edison. So it's a much smaller form factor, but we're still having some power problems with it that we have to work out.
The photos on the screen demonstrate where we were at the initial hackathon, and the photos closer to the right are more where our development is today. Proxome's biggest impact will be in reducing the speed of response to infections throughout the world. The cost and reusability of our device is so low that it could be deployed to millions of people and tens of thousands of healthcare workers. Our open source software makes this device available and able to be customized. By decreasing the time it takes for patients to be reached and a response is mounted, Proxome can save many thousands of lives in any large outbreak. Thank you.
So love anything that sort of leverages and exploits remote monitoring to extend the reach of the physician or the caretaker. And it appears like that is what this solution does. What I'm not entirely sure I understand is what is sort of the unique or novel aspect. Is it around the economics that this is a very, very low cost deployment and that's why it's different?
And the simplicity. By making this entirely voice activated, which no displays, no keyboarding, this can be used and modified locally even before the infection strikes. And so we have now this concept of pre-positioning assets in order to reduce the speed of response. Every day saved in doing in managing this, and what we discovered, not we, the international, was discovered that trust was really the major barrier to introducing technology or introducing care into these environments. So we're trying to deal explicitly with the ability to have a low enough cost, long enough longevity. These beacons do not have to be recharged. They last 2 years. This is technology that already exists on the shelf for $10 to $20. But what we're innovating here is how it is being used as a way to control the infection spread rate, as well as to make it safer for people in the ETUs themselves.
So is this a sort of low-cost wireless telemetry that would be used in healthcare facilities, or is it more to be used in the community to...
It's both, because the proximity works to your advantage. In other words, telemetry itself does not care about distance. So it works if you have wiring in a hospital, in an ICU, if you know what's going to happen. But in these settings, whether it's a put-up hospital or a community that is seeing infection, or where you're just running a training exercise, you have to do the geofencing thing. It's like those pet fences that you would, before Bluetooth. You have to have like indoor GPS. Some people call this technology indoor GPS. And that proximity technology means that you can set this up without needing a wired ICU or infrastructure like cell phones or internet connections.
But it's meant to be used on patients, not people who are walking around in the community to see when they get sick.
Because the beacons are invisible.
Yep.
And they're paired, but you don't necessarily know who's wearing it and who's infected. There's a privacy component to this that, again, can be done within the community, because only the people with the beepers can know what the beacon is saying. So we have both halves. The caregivers know who the patient is and something about the alarms that they've set, whether they're proximity or heart rate or temperature alarms. But the other people in the community don't know who's who. They're not wearing something on their forehead.
Thank you, Proxome. And now, welcome personalized normal temperature, Mark Hoffman.
Before I start, I want to share some acknowledgments. Jim mentioned that we could do this. My family, who's been Ruth, Jordan, Sophia stole the show in my entry for the video challenge. The Janik family that inspired this entry. All of my supporters in Kansas City, everybody who voted. Ring is already proving to be a great collaborator. I'm looking forward to working with them, and of course the sponsors and organizers. So with that, I want to tonight I want to talk about what I think of as a new concept of personalized normal temperature. So I'll share why my team is qualified to perform this work. I'll share a little bit about the family that inspired my entries. I'll share a little background on why our measurement of body temperature is actually in need of a re-envisioning. So I bring 18 years of experience in both industry and academia, so I understand a public-private partnership from both sides of the equation. I'm eager to work with Ring. I have a great sense for what they need. I've served in executive leadership at a large electronic health records company. I'm an inventor on 16 issued patents, so I have a great sense for technology development and validation, and that's really how I see this project. So the inspiration for my proposal is a family, Ava, Lucy, Oscar, Janik. These three beautiful children are friends of ours. They all three suffer from complex symptoms that haven't been fully and appropriately diagnosed. Pain, rash in response to high temperatures, and they have frequent temperature regulation problems where their average body temperature can either run low, 97, or high, 99. And that makes communication with their providers very difficult and challenging. Reflecting on their situation prompted me to really ponder what is normal and how did we get to our concept of a normal body temperature. One thing that I think distinguishes this is that every single encounter with the provider involves checking vital signs, and of those, body temperature is, of course, one of the most important. The process is a provider evaluates your temperature. They compare that to a population-based average, not your normal average, but a population-based average. What we may not know is how we got to that average. So The value that they use, 98.6, is based on a German study from the 1800s performed by Karl Wunderlich using thermometers that were about a foot long. They took 20 minutes to calibrate. They've been proven to be inaccurate from going back to museums and recovering these devices. But that's still the value that we use. This study has not been validated on a large scale, and it's really grossly out of date. We know that there are other factors that influence temperature, gender, time of day, age. These are all factors that influence our temperature. So this is actually a much bigger issue than we see in these rare pediatric conditions. Temperature dysregulation is a known factor in many endocrine conditions. It's common with immune compromised, autoimmune conditions, traumatic brain injury, and a variety of other conditions. There's been a recommendation that was described not so long ago in the Harvard Health publications saying that they recommend that we should all have a baseline temperature that has times from multiple times per day, but this is not happening. One of the reasons why is technology. So it would be very tedious to do a study with frequent manual checks of the patient, tedious for both the patient and the researcher. The only other option is a wearable device, but that uses rectal wearable thermometers to generate a continuous stream of data. I really don't think there's a big market for that type of device. So I was really excited to learn about the Ring wearable thermometer. It's already FDA approved. It's an axillary patch. Some of the judges have concerns about battery life. This device has a proven battery life of up to 120 days. It generates data every 4 seconds. It feeds from the patch to either an iOS or an Android phone, so it is multi-platform supported. And then that data can be uploaded to a cloud-based analytics platform for clinicians to perform fever surveillance and then the research that I'm describing. So my research strategy is to enroll a group of consented subjects and combine the continuous temperature measurement data with additional health indicators such as whether or not the child has a cough, sore throat, and other indications of their health status, merge that data, and then the deliverables that we anticipate from this would be a new methodology for integrating continuous temperature measurement with health status, and more interestingly, a new initial model for what I think of as a thermogram, which would be a communication device. When you go to your provider, if you have a data-driven concept, a report or an app that you can use to show my average temperature is 97 degrees. So for me, 2 degrees increase of 99 is a fever, even though you might not think so. So if you have a data-driven resource, that helps that communication. In discussing my project with Gina Janik, the mother of the children in the picture that I showed earlier, she said that this technology would be life-changing for their family. It would help them make daily decisions such as whether or not they can simply take their children to the pool on any given day. So I think this project provides an evidence-gathering basis to expand the market potential for an already exciting new product, the wearable thermometer. Thank you. Happy to take questions.
So I wonder if you can just clarify, because this is a very exciting application. And so is your connection with Ring, as you're speaking as a application for Ring, or is this a separate business model that you're using the Ring device as a as kind of a platform for?
I think it's similar to some of the other examples earlier tonight, where the relationship is new and evolving, but the first thing I did after learning about advancing to the finals was get in touch with Ring. So we could go either way. My intent is really to validate the technology using this new concept, and so that's what I see as the relationship.
And then presumably building kind of the software kind of wrapper around it.
Right, and so prior to filing my entry, we did file a provisional patent just to protect our business options at the university to license the intellectual property that might evolve from this. Chris has.
Just have a clarifying question. So, how long does it take? First part is how long does it take to actually baseline your personal temperature?
That's part of what we'll have to define, but I think a week, I think of it similar to a Holt monitor in cardiology, where you wear a Holt monitor for a couple of days, you gather your information, and that gives data that's then used to communicate with your provider. So I think of it in a similar model.
Okay, so assuming, in a scenario, assuming now I have children, they're sick all the time, so I usually only take their temperature when they have symptoms or when they're abnormally behaving more than their normal abnormality of being crazy little kids. But more importantly, I guess how do I detect that now? Are they supposed to wear it all the time so that now we know that they've gone beyond the, it's pre-symptom, but it's throwing a fever, and how do you use that?
Right. A couple of models. One is for determining what the average is and then storing it, and then you don't have to wear the thermometer. The other model is for fever surveillance in patients who are at high risk. So the earlier you can detect a fever, the better. So it's a good question. Thanks.
Great. Thank you. Personalized normal temperature. And last up, we have automated interactions and locating devices, Charles Clark and Amu Sushila.
Hi everyone. Before I start, I would like all of you to just close your eyes for a moment and think about what you did at 5 o'clock today before you walked in through these doors for Google Wearable Challenge. Now, what is your schedule 5 days from now? How many of you feel confused, lost, or blank? Our human mind is a flow of thoughts from the past to the future. And although it's a blessing to live in the moment, it is your ability to connect these thoughts that help you to be functional and productive. People who have dementia lack this disconnection. That's why they keep clicking pictures of people to remember or go on a date for 50 times for the same guy. But in real life, I'd like to tell you a story about two lovely dear friends of ours. She's an 87-year-old woman who has dementia, and her husband is a 93-year-old retired physician. Her day starts something like this. She gets up in the morning, she doesn't know what to do. She goes blank. And her husband reminds her, "Dear, it's time to have breakfast. Darling, it's 9:30, take your medication." So in this way, she keeps herself going. This is not just their story. It is a story of my grandma, Charles' grandfather, and many more people.
Alzheimer's makes up about 70% of the dementia cases. There is, in the US, 5.2 million Americans that have Alzheimer's. It is roughly a $226 billion a year industry, and with $44 billion coming straight out of the pocket. It's a high stress for the patient, and it's also high stress for the caregiver, with the caregiver saying 59% are saying it's very high emotional stress. So we came up with a solution to help deal with this stress and relieve the anxiety, and at the same time, it will produce a more fuller day and a more productive. It is called Elaine. It's a wearable wristwatch type device, and there's two ways to record and remind. Directly with the device, you speak into the mic, it goes into the memory, you set the date, set the time, and then it will automatically replay when it comes to that alert.
Just to be reminded to push a button that's so easy and get the recording, it would be wonderful.
Lydia, it's 6 o'clock. It's time for dinner. Come into the kitchen. Lydia, it's 6 o'clock. It's time to have dinner. Come into the kitchen.
I certainly can use it, and I could get you a lot of people that can use it too.
These people were not actors, and the results were exactly what we were hoping for. So the other way to record and remind is from a long distance, and that's using your PC. You go into the website, and you record your voice, And then you set the time, and you can send it to either one person or multiple people at the same time. You set it for the specific time and save it. And this could be used in executive meetings or emergency situations.
So based upon the talk we got, we called it the talking watch, and we conducted a survey. 86% of the people who came across had somebody who knew a first-hand knowledge of dementia patients, and 99% of them said wearing a watch was way more easier. Now, 86% of them told that it'll improve the quality of life, and when they asked if they would use it for their purposes, they said yes, they could use. 60% of them said they could use it for a second voice. So we hope Elaine brings less stress and more productivity in people's life and bring happiness to people and your loved ones, because happiness is not the absence of problem, it is your ability to deal with it. Thank you.
I think the application is very, very important. We've all read the literature about Alzheimer's. What I'm curious about is, why did you decide to develop the entire hardware device as opposed to an application that could be used with sort of Samsung SimBand or sort of an Apple iWatch app?
So the first target population was dementia patients. So for them, a high-tech device would not work. I mean, they wouldn't like a touch screen. They would want something which can push a button. They are not familiar with gadgets. So a simple wearable watch, which they have been wearing all their life, if they start talking to them and telling what to do, I feel they'd have more response. But we are developing an app which could be used for other purposes, like kids who would not need to be reminded, or you need to be reminded about some emergency situation. For that, an app would work. But for these patients, I feel the watch will be the best.
Can you set the alerts on the fly, or do you have to actually go into interfaces? Can you have do like Nest does, where they're going to eat and you say?
Okay, if it's directly on the device, you can do it live time, actual, on the fly.
With voice, or do you have to go in through one of those?
It'd be with your voice. So
with voice.
Yep.
Okay.
Great presentation. Can you talk a little bit about the state of development, where you are with regard to prototypes, piloting, data you've collected beyond anecdotal data?
So this is developed by, so it has three components. It has a hardware component, which is the watch, and the software part, which actually manages it and executes it. So the manager is the one which installs these recordings, which is a computer-based application, but the executor software is a part of it. So we are actually, the developer is not here yet because he couldn't fly off. He's in India right now. But we are actually developed the device, and next step is to bring it to an old age home and test it on a group of people and have more feedback to improvise on it. So.
Fantastic, great. Thank you guys. So those are all the presentations. Wonderful. The judges now are going to exit to the deliberation room. Jim Ryan is going to escort the judges to the deliberation room. And we're going to have 4 wonderful panelists come up here, and our managing editor, Jenny Whalen.
All right, everybody. So while we wait for the judges to make a decision, we're going to have a little conversation about where wearables are today, what the trends are, what we're looking at, what the challenges might be, big picture. So as Jennifer said, I'm Jenny Whalen. I'm the managing editor of MedTech Boston. If you have not heard of MedTech Boston, I'd love for you to check it out. It's a healthcare innovation website, medtechboston.medstro.com, so connected to Medstro. And we cover all sorts of things, healthcare healthcare innovation is the core of what we do. So if you have a good story, if you want to write, email me. So to get started, we're going to have our 4 lovely panelists just introduce themselves very briefly. 30 seconds, guys. I'm holding you to that. And then we'll take some audience questions. So if you guys have questions, be thinking of them, and I'll run the mic out there. So Yiding, ladies first.
Sounds great. My name is Yiding Yu. I'm a resident in internal medicine at the Brigham and Women's Hospital. I also work as a primary care doctor at Harvard Vanguard. I'm also the co-founder and chief medical officer of an app called Triage that allows ambulances to send direct alerts to hospitals about sick incoming patients.
Hi, my name is John Silva. I'm at Tufts Health Plan. It's one of the major health plans here in the Commonwealth. I'm in the New Ventures unit. We involved in investments, corporate development, and M&A. I'm also an investor with Genesis Capital Group. We're focused on private placement investments, and I'm primarily focused on early stage healthcare investments.
Hello, hi there. I'm Arsha Vahabzadeh, and I do 3 key things. The first thing, I'm a vice president at BrainPower, the keynote speaker. We build software for autism, and our platform is Google Glass. The second thing I do is I'm a child and adolescent psychiatrist at Harvard Medical School and Mass General Hospital. And finally, I'm the incoming chairman of communications at the American Psychiatric Association.
Hi, everyone. My name is Sean Gandhi. I am a 4th-year medical student at Harvard Medical School and a 2nd-year business student at Harvard Business School. I'm also the co-founder and chief medical officer of Wellable, which is a corporate wellness program that allows anyone to bring their own wearable device to use on our corporate wellness platform.
So we have some very qualified folks up here to answer your questions. There are 2 mics actually back there. Looks like just one right there. So if you have questions, please feel free to hop up, wake up, and go to that mic and ask. I'm going to start it off. I would like for each of you to give us your sense of where we are at with wearables right now. What does the wearable world look like? Where are they being used the most often? Where do you see challenges?
All right, I guess ladies first again. It's a tough question to gauge the entire market. I would say that for me, thinking about patients in my clinic, where I see wearables most used are still in the consumer market. We're talking about Fitbit, and really it's mimics and its cousins. We're seeing more in Google Glass. We're seeing much more in terms of wearables that have a specific, much more niche product. In terms of the penetration into actual healthcare space, I think it's still very young. And I think many of the real potential can be in harnessing more popular devices for clinician use, like using that data and driving both patient and provider decisions.
So I'd like to bring up I'll call them the unwearables. So companies like EarlySense that are using sensors, not physically touching the patient, but very physically close to the patient. This can avoid the challenges of getting the patient or whomever you want to use technology to physically touch it. But if you have many such products in the home or in your work, but are not physically touching the patient, but very close by, this can really speed up the adoption.
So where are we with wearables? Well, all of us actually have a smartphone, right? We all have a phone in our pockets. Is that a wearable? Because that's a pretty powerful computer. I like looking at data. And I think one of the things that we know is just under a quarter of the US adult population has purchased a wearable device. And in mid-2012 or so, about a quarter of the population had some kind of tablet. So what we know is over the next 2 years for tablets, we saw a doubling in that amount. Up to 40% of people had that. So if we project out in the wearable space, we may notice the number of people that have a wearable over the next couple of years may in fact double.
So I think we're really at the cusp of innovation when it comes to wearables. If you think about the history of technology, the personal computer was actually invented first before we actually identified all these different killer apps that we could use for it. You see it time and time again with cell phones, with any type of device, that the device ends up being invented first. and then we come up with a lot of really innovative ways in which we can use it. So I think we're really at that point in wearables now. Now that we have a lot more devices that are out there in the market, now we can really start thinking about how we can use these. And I think tonight we've seen all the different innovative ways that people can actually use these devices to do some really cool things.
Okay, so let's take some audience questions. Does anybody have any burning questions? I have some more of my own, but I'm sure you guys have some thoughts or questions about what's going on here. Yeah, there's one. You can grab that mic. Sorry to make you walk.
So a lot of the wearables I've seen kind of address the worried well, people who are already healthy would say fitness trackers. How do you see wearables reaching the people that need them the most?
So I can take that. So I'm a big believer in wearables integrating very seamlessly into someone's life, into someone's kind of life flow or workflow, so to speak. And I think right now what we have with a lot of wearables is that you have to remember to put it on, or you have to remember to turn it on, or remember to press a button. And I think for a lot of people who are, as you say, the worried well, they remember to do that. I think for a large number of us, I think myself included, I have a couple devices that are just sitting in a drawer right now because I just forget to put them on. And I think if there's a way to make them more human-centered so that you just can't help but remember to put them on, or if they're just integrated into your normal life, it's hard not to use it, and as a result, it can actually collect some really useful data. It can actually make a difference in your life. So it's all about making it more human-centered and integrating it more into our life.
I think the first part of your question actually raised something that's really important that I'd like to just make a point about it, is that a lot of the people who are purchasing wearables that have got these products tend to be early adopters of technology. And what we know about that group is that it tends to be younger, with a male predominance, and also these are not the groups of individuals who tend to have a lot of chronic medical conditions. So really, it's a very different demographic to the demographic that a lot of hospital systems want to target. So I think I just want to I'm not sure if everybody kind of was fully aware of that, but it's a very different demographic and really speaks to the need to produce technologies to help individuals with chronic disease.
I'll draw an analogy. So if WebMD was a website used for a general audience, Patients Like Me is a software platform for specific communities. I think in the same respect, a Fitbit or similar platforms for wearables for a wide variety of people to use, you're going to have extremely specific devices for might be a very, very specific, relatively small community, much smaller than, say, autism. And that's the way you're going to have success.
I think this is also to John's earlier point about ambient monitoring, where instead of requiring a patient to actively engage, actively put it on, you have sensors in a room, or you have a part of an application of a watch or phone, and you don't have to turn it on. It's not an app that you need to engage or take photos or selfies with. Those are my friends on their own Fitbit. But these are monitoring daily activities for patients with dementia, for patients with mental illness. Software companies like Ginger.io are trying to collect this ambient data to really build powerful inferences. I think there's great potential in big data, but we really are still waiting for that big break where that could be really triggered to allow hospitals to make a difference in readmissions and patient care.
Thank you.
Good question. Thank you.
Knowing that remembering to take your device is a problem, I suspect there are 10 people in this room that have a dog that has a pellet so that when he runs away, that can be scanned. Why don't I have a pellet so that when I go to the emergency room, my electronic medical record is easily identifiable, and so there can be all kinds of information that I willingly will share with you if, in fact, the right person scans my pellet?
I think that's a great question, and there are a few reasons why there's been challenges. In the hackathon community, that idea is brought up over and over and over again. I've seen it over and over again. So you're not alone in thinking that is something that would be lovely to have. But we live, I think, in an incredibly segmented marketplace, and I think that's actually the primary challenge to this. Maybe if there was a very large health plan that offered something like this for all of its patients, we could make an inroad. But right now, having a medical record that can be shared with any hospital that you need to go to, it's still a very early stage. I would love to see it happen.
I think it just depends on whether you'd like to have a pellet kind of implanted in you. I don't know. I haven't really thought about that, but I don't know. It sounds like a kind of a cool idea. If it works for my dog, I don't know, it may work for me. But yeah, it could work.
Actually, Blue Cross North Carolina has actually spun up a company down that road, this all-purpose type of electronic identification. It's really a matter of integration, and also it's simply a matter of how, very much an issue of the cultural divide between early stage technology development and corporate development. And I have been an entrepreneur, and I've been in the corporate side, and you need to be able to speak the same language, and it's not easy.
How many of you would have the pellet put in?
I'd do it.
Sure.
Yeah, that sounds cool.
I don't know if I would just implant it. I prefer like a bracelet or a necklace or something, or on my keychain maybe.
But I think there's two important barriers that stop a lot of these wearables actually coming into the health space. If you ask physicians or other members of the clinical team, one of the concerns is, am I going to get paid for interacting with this wearable, which is a pretty important consideration for a lot of physicians and other clinicians. The other factor is that whenever you have patient information out in the field, out in the hands of other people, that makes a lot of clinicians, physicians, and hospital organizations quite wary. So those are two kind of key things that are barriers into going forward in the wearable space.
Yeah, go ahead. Next one.
And actually, I think that's a perfect segue to this question. So we've had a divide in the industry for a long time, and we've seen it tonight in the demos and in these questions as well, between kind of healthcare-centric devices, things that hospital systems and payers have put forward, and then consumer devices as well. So how would you recommend that we bridge that gap moving forward? Should we be moving the healthcare systems over into the consumer device space, or trying to get more advanced devices in the hands of consumers? What do you think will happen in the near future, and what should we be doing to push things in the right direction?
I'll address that from the perspective of systems. Providers and payers have so much clout regarding the influence as to what will be used in the hospital, what's going to be paid for, that I think in an ideal world, it would be a meeting of minds between early stage entrepreneurs and corporate leaders, but you really need to get buy-in, and there are some health plans and some hospital systems that are very, very forward-thinking, and some that have the budgets to really put forth into innovation, and it's not easy. And so the answer has to be corporate leadership, institutional leadership that can find the budget, but also the willpower to work as closely as possible with new innovative startups.
I think it just depends on what the consumer interface really is. So, like, take into account, for example, my work with Wellable. I mean, we don't work necessarily with payers. We work with employers that want to enact corporate wellness programs. And what we found is oftentimes consumers have their own preferences about the particular device they use or particular app they use. Like, I use Runkeeper. A lot of my friends use Endomondo. A lot of my other friends use Jawbone. And these are all just very specific choices. And I think when you have a consumer marketplace, there is going to be a diversity of choice when it comes to the particular interface that people want to use. And so at least what we do is we try to bridge the back-end gap so that any enterprise customer can use any one of these devices to push their own information or to extract information. I'm biased, but I kind of feel like that's going to be part of the future. Consumer devices that get adapted by enterprise customers.
Thanks for a really great discussion. I have a question. I'm very interested in promoting health in low resource settings, whether that's in the US or overseas. Do you see wearables as exacerbating disparities in healthcare access and outcomes, or do you see it as having potential to really democratize access, and if so, how?
So I might start there. I think one of the considerations is for wearables, what is the price point that we're looking at? So in our work at BrainPower, we want to make sure that we have our software on Google Glass accessible to as many people who, as many children with autism as possible. But that really comes down to a price point issue. The ability to expand wearable technology in the developing world is pretty dependent on the price point, but also if you look at the developing world, there's not a lot of medical practitioners, medical systems may be underdeveloped, and technology allows us to exponentially scale our ability to deliver wellness, healthcare, educational tools. So it really comes down to what's the price point, what's the sustainability, how are we going to support those wearable devices in the field. So I think it has immense potential, but we have to make sure it comes at a right price point for those communities in order to be utilized.
I also think that there's a great potential for communities that are traditionally underserved to improve access. So my patients who are working 3 jobs, who have to support their uncle, 5 people living in their own households, they have a really tough time getting into my clinic to see me. So a wearable that allows me to communicate with them more easily, to have their data, a wearable that allows me to check on their blood pressure so they don't have to come in, or even for a nurse visit is very difficult during normal working hours. So I think there are many things that we can do for virtual visits, for enabling access that can improve healthcare, especially for patients who are traditionally underserved, while patients who have more resources can easily come and seek healthcare in many ways. So I hope that's, in addition to price point, something that's available for those communities.
Hi, I'm Jeannie Marcus, and I'm a pediatrician in the western suburbs here. And I had a thought about the wearable that takes a temperature. Young kids get something called febrile seizures, and the seizures actually happen at the time that the temperature rises. If you take the kid's temperature and it's already 105, then the risk of a seizure at that moment is very, very low. But if they go from normal to 105 pretty rapidly, that's what tends to trigger it. If the family has experienced one febrile seizure, they are freaked out and they want to prevent a second one. So you put one of these little, tags on their kids, and trust me, they will put it on every single day until the kids get to be 2 or 3, when they kind of outgrow the risk of febrile seizures. And so as soon as I saw that, I said, oh, that's the one way, that's a complete useful way of using that particular thing. So I think that in this room, you're talking to the converted, and you need to get it out of this room to the place where people will adopt it. I sit on a committee at the American Academy of Pediatrics that is looking at new technology, and we ran a workshop at the annual meeting last year on, new devices to use in the office. It was absolutely overwhelmed. And so this year, the Academy people came back and they said, will you give it twice? And of course, everybody who was involved in it said yes, 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 because there were so many people there that they couldn't get their hands on the device to look at it, to see how it works, because there were just too many who showed up the first time. So I think there's a lot of interest in this kind of thing, and but you need to take it on the road.
Yeah, to flip that into a question for you guys, actually, I'd love to know from each of you, with the patients that you're working with, what is the sticking point for this sort of thing? You know what she said, absolutely, my patients' parents would use this. For the patients you work with, or, you know, John, for the consumers that you're working with, what's the sticking point here? How do you sell it? How do you make them turn it on every day?
I think it's just got to be easy. It has to be, you know, maybe this is the room of the converted. You guys are all the early adopters, but there's nobody out there who says wearables is awful or this is not cool. Everybody thinks it's cool. It's just not super accessible. It's just not easy. It's just not right there, right? Apple wasn't the first company who made a touchscreen mobile phones. Microsoft did it. There was like iPods even before. Then there was like the Zune. It was just an awful user interface. It wasn't a great product. But we need to continue innovating until it just becomes delightful and easy and something that you will pick up second nature. And that's hard. That's what great designers and great minds come together to do. But I think until we find that sweet spot, it'll just be very difficult to get it to stick.
One technology application we're looking at is something so simple and so inexpensive that you can find out if your elderly family member got out of bed this morning, or similar very, very simple, inexpensive functionality. This is absolutely on the minds of a lot of technologists, but how to really get it to be a viable business model is incredibly challenging.
So I think that we've had, at BrainPower, we've had many successes, as you can see by the video. I think that meeting expectations, quite huge expectations of people, is a challenge throughout the wearables market. We have gone from passive healthcare receivers to active, engaged consumers of healthcare who are generating data and who will shape the healthcare services of the future. For our own company, one of our challenges is actually trying to get the glass away from the children once we've finished showing it to them. So I think that it varies a great deal. I think there's much progress to be made, and we're in the very early stages of this field.
So maybe I have maybe it's a little bit easier for, at least for Wellable or for what we do, because we work with corporate wellness programs. So as part of that, the consumer actually gets an incentive to actually participate in these programs. So there actually is a particular reward that someone gets for turning on their wearable. But I think you didn't put it perfectly. It needs to be, the design needs to be human-centered. It needs to integrate seamlessly into someone's daily life. And that's how you get people to turn it on, when they don't even need to think to turn it on. It's just natural behavior to do it.
Go ahead.
Thanks. So my question, I guess, is behind the data behind wearables. So a lot on the clinical end of medicine, we focus a lot on evidence-based medicine and kind of the things we prescribe to our patients. We try to kind of derive them from like strong studies that have been done, and kind of wearables acknowledging that sort of in its early stages. How do I, the data's just not there to support the same thing. How do I, when I'm sitting there in my primary care clinic and my patient asks me, should I get a Fitbit? How am I supposed to answer that? Should I say, yeah, that sounds pretty good, knowing that in the back of my head there's not the data there, and how have you guys kind of managed that struggle there?
I guess I'll tackle this one as a fellow primary care doctor, that I treat these wearables kind of like vitamins. There's some data to support some use for vitamins that have great benefits, but vast majority is like a wash. They don't hurt, and maybe they help, but they don't hurt. And I don't think it generally hurts people. So I generally say, if you're interested and you have you're interested in exploring it, I don't think it could hurt. I've not seen in wearable cause somebody who already has anxiety to have even more anxiety. I think if they're worried well, they will continue to do many things to focus on their health. So that's not really the challenge. I would certainly encourage people to use it in my clinic.
So we're going to tackle that issue head on, and we're going to have a clinical trial at Massachusetts General Hospital to address how effectively and how tolerable our Autism software for Google Glass is in helping children. But I as a researcher, as a clinician, I appreciate that difficult spot with a lot of the different technologies that are evolving rapidly. Where is our evidence base when our patients approach us with questions?
Okay, so we're going to take one last question, then our judges are back. So, last one.
Hi, so sort of focusing on the medical field, there are a lot of cool ideas out there for example, medical monitoring or some sort of cloud-based data storage or cloud-based analytics. But in comparison to, for example, the consumer field, there are more hurdles to jump through. For example, HIPAA compliance, or if you're making some sort of medical device like FDA regulations, FDA approval. And so with a lot of startups out there that are trying to disrupt this field, I was wondering your perspective on how do we sort of balance this fast, I don't know, hacker-based innovation with getting through these regulatory hoops?
That's a great question.
So it's a constant battle, and as I said before, speaking the language, the corporate leadership that manages 10,000 people in one business unit has to be able to communicate effectively with a startup with 3 people in Kendall Square. It's extremely challenging. The only way to really do it is for people to physically get together at events like this, and for there to be strong innovation with, incubators like Techstars, for instance, bring entrepreneurs with top corporations worldwide. It's not easy to do, but there are best case examples about how it has been done effectively, and we can talk more about it.
So I think this is really a public policy question. I mean, we've changed in the past with regards to patents and trademarks, and really I think it comes down to places such as here in Boston or in San Francisco, or basically the hubs of innovation in the country, to really make the case to our policymakers that things need to change. I mean, HIPAA was, I think it was 1996, right? I think that was when the law was passed. I mean, that was 20 years ago. I mean, it's things have changed a lot, and I think there is a lot of work that we can do here within the entrepreneurial community to try to get around these hurdles. But inevitably, you're going to hit one, and I think that's where our public policymakers really need to step up and make the rules work more smoothly to encourage innovation.
And just to add logistical advice, I would say, I work on triage. It's incredibly difficult to mount the corporate sale, to sell to a hospital and say, this is the solution. You can find many doctors who say this is a no-brainer, this is absolutely what we want. And we certainly have found those. But to give you tangible advice, I would say, if you're really motivated to build something for healthcare and build something for patients instead of the consumer market, you can really make a huge impact. But you need to find the early adopters among the hospitals. That might not be the big institutions in a big city, even though they have a name, even though they're willing to do many things, because they have many, many more layers of bureaucracy. It actually might be that community hospital that's competing with 5 other community hospitals. And they want to find a way that they can brand themselves as the next cool thing, that they have the cutting edge of technology. So find those early adopter, culture-leaning institutions and work them. Work those people. You can work, there's 5,000 hospitals. So find the ones you want to approach, and that would be the best tangible way while we're waiting for policy and everything else to catch up.
Well, thank you guys very much. Big round of applause for these folks. And as a quick shout out, a couple of these folks are MedTech Boston 40 Under 40 list of healthcare innovators, which if you haven't seen it is a great list of movers and shakers in this area. And we're going to be having an event next month to honor them and to network and to continue this sort of conversation. So keep your eyes peeled for that. And without further ado, we will pass it along to Jim. So we will all leave the stage.
Okay, so we have a winner, and we also have a little bit of a twist. So, as many of you may have been following through one of the emails I sent last week, we have the Crowd Favorite Award, in which we asked our finalists who are here tonight to record just 60-second little fun videos, and then we put them up on the competition site, and we had a week of voting for that. And it's just one of the ways that you can see this is the human side of all the people who presented to you today. And so we are going to switch over to the competition platform, and Jennifer at the back will refresh the page, and we'll see who won. And it looks like it is the team from, what did you call yourselves? Memorandum. Sorry, Memorandum. So please come up. Great, congratulations. Thank you. Congratulations. Thank you. Congratulations. And if you want to watch their video, it's on Medstro. Well, thank you very much. Congratulations. I'm sorry, we don't have anything tangible to give you, but you will, your video will remain there forever. Okay, let me see. So the next announcement is you think it's the big announcement you've all been waiting for, but here's the twist. Our judges couldn't decide on one. Well, they could, but as often happens in these types of competitions when you have a really great field, it's really hard at the end of the day to say, well, this one winner and then don't say anything about the other participants. So they felt really strongly that we should at least mention who they feel was a runner-up. They created that. There was no runner-up award originally intended, but they felt really strongly about it. And it's not an envelope, it's a folded piece of paper. We didn't have any envelopes. Yes. So the runner-up, the rationale behind this was they felt it was a practical problem. It's a problem that affects a lot of people. It causes a lot of pain and suffering and a lot of cost to the medical system. And the science behind the idea seemed really sound. And that runner-up winner is the concussion recovery tracking idea. So where's our winner? Come on up. We'll give you a handshake. Congratulations. Yeah, and thank you for entering the contest. And again, your entry also will live forever on Medstro. So, the winning prize actually comes with a prize, which is all of you here tonight who purchased tickets. All of the proceeds basically were combined into a big pot for the winner, kind of like a door prize. And that pot is now over $3,000. So the winner will be given a check for that once we do the final calculations. And to announce the winner, we have Natalie Schneider from Anthem.
Thank you. So first off, I have to comment that it's been a long while since I've been in a room with this amount of intellectual firepower, and everyone did a really outstanding job. And it was really tough, sort of stack ranking the opportunities. But ultimately, we were given the charge to identify someone that came up with a novel innovation, which means is the space already congested with solutions that are quite similar. That they could execute a pilot, which also means that you have to have a real definition for what success looks like and be able to measure that. And lastly, that it has high impact, which could either mean that it impacts a large population or impacts a smaller population, but makes a really big difference. And ultimately, Brian Caulfield really brought his game today, and great accent as well. And he came up with the wearables for orthopedics. And ultimately, the reason we liked this was a couple of reasons. One is, it endorses that end state that I think we all support, which is empowering the patient to take control of their own health. And secondly, in the world that we're moving into, which is value-based contracting and really paying both providers and physicians for ensuring that there are no readmissions and our patients stay healthy, it sort of reinforces that. And lastly, it's just a very practical problem to a very big need and a very large population. So congrats. congratulations to Brian.
Well, thank you. I'm very surprised, I have to say. Thank you very much. And the reason I came here was to get good feedback. I didn't actually think I'd be going back with a winner's prize. So I think that's the best feedback that I could have got, which is the most positive form of feedback. So thank you.
Congratulations.